I'm going to move on now, but the link for the questionnaire is in the chat, and I'm sure we can paste it again, but please do just take a moment to complete it. So as I said, we were absolutely overwhelmed by the interest in this event. I don't think I've seen quite so many registrations for an online event. And it's fantastic to see you all. And the reason, one of the reasons we decided to hold this event simply is because of that huge amount of chat, publicity, talk about the promise of ambient voice technologies, how people are using them, how they're not using them, what the potential implications and opportunities they offer. But one of the things we've also heard a lot over the last few weeks is a sense of the cat's out of the bag. Lots of people are already doing it, perhaps without thinking about some of the wider implications. And lots of people want to do it with maybe not always confident in some of the support and the things they might need in place to be able to adopt it. So the phrases we've heard are, yep, cat out of the bag, genie's already out of the bottle, but also maybe more kind of worryingly how it's a wild west out there for ambient voice tech. Now, we know lots of guidance has come out recently, and we've got George from NHS England later talking us through the NHS developed guidance. There was also a letter that came out last week from Alec Price-Forbes, National Clinical Information Officer, reminding NHS organisations about the regulations and what might need to be what should be in place when adopting ambient voice technology and scribes. But also lots of conversation on social media and lots of publications about the need for evidence and understanding of some of the wider implications. So this event has really been designed to spend a bit of time in the morning talking through the guidance, learning from others who have already started implementing ambient voice technology, thinking about some of the clinical regulations that need to be in place and how that might be tackled. And also to hear from others, for example, the This Institute around work they're doing around development of an evaluation framework. So the idea really being spending a morning to think about what do we need to know, what are the questions we need to ask, what has to be in place, and then an afternoon to hear from 4 suppliers of ambient voice technology and scribes that are in the marketplace. So a chance to put some of that newly acquired knowledge into practice in the afternoon by hearing from them and an opportunity to kind of question them on how they're meeting this guidance. Now, I should say we selected 4 suppliers. There are lots of suppliers out in the marketplace, as you'll be more than aware. We selected these 4 because they're already in use across the north, east and Yorkshire and Humber region. But just a kind of reiteration that we can't take any responsibility for any of the kind of the claims made. They've been selected as examples, but there are others out there. So please do, consider that when you're deciding what you might want to adopt. So I'm just going to say a couple of words about the Health Innovation Networks. Hopefully you're familiar with us. There are 15 of us across England. I am from Health Innovation Yorkshire and Humber, and there are colleagues on the call, both from Health Innovation North East and North Cumbria, and I think from several of the other health innovation networks across the country. So we were set up really to think about how can we accelerate innovation and research into practice for greater patient, but also workforce benefit. We think about some of those national challenges. But the beauty of having 15 of us is we can really spend time with our local populations, local NHS, to get to the heart of local challenges and think about how we bring that local context when we're thinking about how we adopt some great innovations and what might be most appropriate and beneficial for our populations. We see ourselves as that honest broker, so thinking about how do we bridge that gap between companies, industry, but also healthcare and what the system and our patients need. I'm not going to spend too much time talking about this, but from a personal perspective, we're really interested around how do we make innovation work? What are the conditions that are needed to ensure that the promised benefits do deliver? And that's part of the reason for this event today. How can we really learn from you about what makes ambient voice technology and scribes work in practice? So I will stop talking now, but I'm just going to do a quick run through of the agenda. So as I said, the morning is really around learning, thinking about the new guidance that has been produced, what support there is out there, and to learn from others who are already implementing ambient voice technology. We'll have a break halfway through the morning. We'll also have a short break for lunch. And in the afternoon, we've got 4 suppliers who have about half an hour each to kind of do a demonstration with some time for you for questions. So quick run through the agenda. We've got Joyce, who will remind us of why we're here, to think about that patient and public perspective. George has kindly joined us from the NHS team who wrote the guidance. We've got 2 primary care colleagues, so Dr. Mike Smith from North East and North Cumbria, talking about the practical things that will need to be in place when we think about clinical governance for ambient voice technology. And then a fantastic example from Dr. Andy Noble from the Jean Bishop Integrated Care Centre, where they've implemented Heidi Health. We'll then have a short break and then a chance to hear from Professor Niels Peake from the Healthcare Improvement Studies Institute about the work they're doing, both to create a kind of a community of practice for this, but also what might you need to consider when we're thinking about evaluation. We've then got a chance for a bit of discussion. Please do stay on. I know the temptation is to jump off when we get to breakout groups, but really to learn from others and have a discussion about what outstanding questions you might still have for this. We'll have a lunch break and then we'll go into the supplier demonstrations. So I'm going to stop sharing now, hopefully. And I'm going to ask Joyce just to give a public perspective on the potential and implications for ambient voice technology. So thank you. Thanks, Joyce.
Hello, everyone. It's good to be with you today. Just a little bit about me before to explain maybe why Laura asked me to say something before I go into the bit about the public and AVT. 13 years ago, after 30 years of working in teaching and training, I had to give up work due to ongoing and increasing health difficulties. I found it difficult to get suitable and timely support and care, and I did not feel that I was truly heard or the impact of my situation understood. But this led me into working with charities that support patients to live well with health conditions. So I still retain that input and have lots of sort of contact with patients. And it also led me into patient and public involvement roles. I really wanted to ensure that patients could have a say in and also help to shape the things that ultimately impact them and their care. So I was delighted when Laura asked me to speak today. Artificial intelligence, AI in general, and including ambient voice technologies, AVTs, are really developing fast, and I know very little about them, but they will most definitely impact on patient care. Yet the general public know very little about how these can be used within health and care or how they might impact them. And in recent conversations since Laura asked me, that I've had with patient groups, local communities and networks, I started asking for people's views about the use of AVT in healthcare. I wonder if you are also having direct and ongoing conversations with patients, carers and the public about your plans for using AVT. In my conversations, most people had no idea about AVT or that it was being introduced into healthcare situations. And there was often an element of fear and suspicion. And after a brief explanation to my sort of limited capabilities that I was able to give to them, people had a range of responses. For example, a 90-year-old stroke survivor who uses voice recognition software on his phone to help him in his daily life after having had the stroke, and a 75-year-old retired program manager who during his career had been responsible for chairing meetings and writing meeting summaries. They both quickly recognised the value that AVT could have to health professionals and patients. A group of charity administrators expressed concern about data security and referred to recent public data breaches. And a small group of teenagers, several who had mental health difficulties, they said they felt uneasy about their personal conversations being listened to and the uncertainty of what would happen to their data in future. The conversations highlighted a sort of complex interplay of concerns and queries regarding ethical, practical and emotional factors. Now, the wider public will bring many more perspectives. They'll bring aspirations for AVT, and they'll have concerns regarding AVT's use and the use of AI more generally. So it's imperative that you engage with people to explore their views. And within such discussions, people will value you being open and transparent, and being prepared to have those difficult conversations. This all helps to demonstrate to people that you are trustworthy and that you will be responsible custodians of their digital data as you increasingly introduce AI solutions across healthcare. However, if you don't engage effectively with the public about the use of AVT, you will leave a growing number of unanswered questions and concerns with mistrust and doubt about its reliability and safety. So ensure you take people with you on the journey to embed AVT and other AI tools in healthcare. Patients, carers, and the public are actually potential powerful advocates for you and your plans for AI and AVT. Patient pull can encourage innovation adoption, and the support and confidence shown by patient advocates for what you are doing can also help strengthen wider public acceptance. However, to engage and involve patients, carers, and the public effectively, you will need to adequately resource the communications, engagement, and involvement functions, because it takes time, lots of time, to build trusting relationships with people and communities. Among other things, you will need to consider staffing and funding. PPIE is so often underfunded and often exists on a shoestring, but I really do believe this is a false economy. How much will you allocate to these key functions so that they can operate effectively, supporting you in what you are doing and ensuring you build and sustain public support, bringing the public with you on this journey? I realise that many of you are doing involvement and engagement already, often on an individual use case and location scenario. I ask you all to consider this might be an opportunity to collaborate and develop a shared approach, which will improve communications and understanding about the use of AVT and more generally AI in health and care. If so, what would this look like so that it serves innovators and the organisations supporting them, healthcare professionals and commissioners adopting AI in their work, and people and communities within your region? How will you ensure you hear public views from across the region, urban, rural, and coastal communities, different ages, ethnicities, socioeconomic backgrounds, and seldom heard groups? Each will have different experiences of healthcare, and will see the introduction of AI tools, including AVT, from different perspectives. So the sooner in the process you engage with the communities and the people you seek to serve, and the more open and transparent you are about plans for AI and AVT, the greater the potential for earning public trust and gaining their support and acceptance of new technologies that will benefit patients, healthcare professionals, and the wider healthcare system. So I look forward to working with you and travelling with you on this exciting journey. And thank you for listening to me today.
Thank you so much, Joyce. I really appreciate your time. I think you said a couple of really interesting things, well, many interesting things, but the two kind of highlights for me, the trust. How do we build trust in these systems? And you talked about that suspicion at the start where people weren't quite clear about what it was, and then moving to a kind of an understanding and potential benefits. I really love the idea of that shared approach to public engagement on AVT, rather than us all duplicating the wheel, but how do we get to a really grounded understanding? So huge thank you, and I'm sure there'll be lots of questions and thoughts on this. Patient consent, I know, is part of the new guidance. I'm now going to ask George to come in and talk through the NHS England guidance that was recently published. I can't see on screen, but are you there, George?
I am here. Thanks very much, Laura. I'm just give me a second, if that's okay, just to upload the slides.
Thank you.
Have they come up?
Yes, they have. I can see them.
Oh, okay. All right. Of course, my computer is slow today. But anyway, great. Thanks so much for giving me this opportunity to speak with you. I would also like to thank Joyce for that important steer that she has given us. So I am George Onisforu. I am part of the AI adoption support team that sits across NHS England and the Department of Health and Social Care. And part of our focus is to develop guidance and resources that can help the safe and proactive update of AI technologies in the NHS. And as part of our work, we have released guidance last month that you may have seen on adopting ambient scribing products that I will take you through today. I should say that I won't be discussing specific products or systems other than as indicated examples, and I won't be able to give you advice on questions that relate to specific products and circumstances. The purpose of this presentation is just to share with you the information that is provided in the guidance. So what are we talking about? You may already be very familiar with these technologies. They are widely used, particularly in primary care, but it might be good just to provide a quick overview so we're all on the same page. Essentially, ambient scribing products, which some call ambient scribes or AI scribes, and they do include ambient voice technologies or AVTs. So these products, they use advanced speech technology, which is now supercharged by generative AI and large language models to listen quietly and capture the conversation between a professional and a patient, and then they transform it into structured documentation. So all without the professional taking their eyes off the patient. And of course, the NHS has been using dictation systems for a while, but previously those tools could only transcribe. Ambient scribes go further than that. They can summarize, they can populate the electronic record, they can even draft letters or referrals using that same audio. Now, the fact that they can have many functions is really important. Perhaps it is the most important characteristic of these products. And you should understand and clarify these functions before adopting them. The different functionalities relate to different types of risks involved, as I'm sure you understand, and by extension to the safety and regulatory requirements, as well as considerations on how these products can be integrated with existing infrastructure and systems. So, for example, functions like suggesting tasks or even clinical actions are obviously higher risk, and they should be considered differently to, say, a simple summarization of the consultation. So you should always return to the agreed intended purpose of the product and ask, does this functionality go beyond that? Now, this type of clarification and the need to support settings that are considering adopting ambient scribes is what drove us to develop the guidance that we released last month. And we released the first two documents of what will eventually be a series of documents aimed at different considerations and audiences. You can see the link there that takes you to what we publish. I can share this later in the chat if helpful. And just to say that the first available document is very brief and high level. It is aimed at senior leaders and board members, mostly just to make the case for change and outline the benefits. And then the second document, which is longer and more comprehensive, is aimed at chief information officers and chief clinical information officers who are leading the adoption of new technologies at their settings. And I will provide an overview of the contents in a bit. But first, as I mentioned, these are only the first installments. Over the next few months, we will update these documents and publish further guidance, particularly on information governance considerations. And that will include a model data potential impact assessment and sample hazard logs. And just to preempt some of the questions that you may have on that, and I guess just to address some of the points that Joyce raised, we expect that the document will provide further guidance on information governance, to have clarifications around your obligations under information law, so things like lawful basis for processing data, things like patient consent, transparency, which is really important, checking for accuracy and record retention, as well as the individual rights under UK GDPR, like the right to object and the right to access. And as I said, we also plan to provide a sample DPIA. So this we anticipate to be ready sometime next month. And we also want to clarify what good assurance of these products looks like. So we are working on a suggested approach that will be published to assist you. So in short, there will be more practical tools coming. Now, in relation to the guidance that is already available, I would encourage you, of course, to have a look at the document if you haven't done so already. But what I'll do for the rest of the presentation is provide a brief snapshot. And what you see here summarizes the benefits of ambient scribing products, which are outlined in that brief overview document for executives. These are emerging benefits from existing trials, and there are many across the system. The largest one is conducted, and you may be aware of this, in London, and is led by the Great Ormond Street Hospital, and it's expected to be finalized this month, with sort of the findings becoming available within the next few months. So what we are seeing with sort of the evidence emerging from the trials is that by automating documentation, these products can cut down the time that healthcare professionals spend on paperwork. And then with the AI doing most of the documentation, professionals can obviously give their patients their full attention during the discussions, instead of having to focus on their computers and typing. And I'm sure you understand that this can enhance the face-to-face interaction and patient satisfaction with these consultations, and essentially, that can lead into strengthening the connections between patients and healthcare professionals. But also, as important, but by minimizing the workload, ambient scribes could shorten the effective consultation time, or the time needed after the visit for the documentation. And you can see that over time, this could lead to cost savings. These projects could also potentially produce more comprehensive and standardized notes than manual entries, which could lead to better decision-making and continuity of care. Ultimately, these benefits, point to better patient care, but also operational efficiency. Okay, now from a practical perspective, if you are an adopter, the guidance asks you to begin with 5 critical moves, and hopefully this will resonate with what you already do. The first one is to appoint a clinical safety officer who will map the involved hazards that these products introduce. And you should be aware that products that use generative AI can produce errors in their outputs. So this needs to be mitigated accordingly. And that takes us to the second step, which involves completing your DCP 0160 safety case alongside a data protection assessment. The third step is about planning integration early, ensuring the product can talk to your main IT infrastructure, your systems and workflows, particularly the electronic patient record system. The fourth step is about locking down firm controls, so clarifying whether the product is a medical device, considering related staff training, and making sure that every output is reviewed by a human. I'm going to pause here around the regulatory considerations. So we worked with MHRA to provide the statement that's included in the guidance, and essentially that ambient scribing products that inform medical decisions and use generative AI for anything other than basic transcription would likely be medical devices. We have heard since the guidance has been published that it will be helpful to provide further clarification on this, including what specific classification would apply to each functionality that Ambient scribes have, given that this, this is not explicitly said in the guidance. So we are in the process of finalizing, official wording from MHRA in relation to this. But you may have seen the letter from the National Chief Clinical Information Officer that Laura mentioned at the beginning, asking that any products that perform summarization require Class 1 medical device status. And then anything further than that, like generative diagnosis, will need a Class 2A. As I mentioned, we will publish this clarification as part of updating the guidance, which was always intended as a sort of like an iterative document. Okay, and just to return to the 5 steps, the last one involves implementing a monitoring framework with audits, incident reporting, and performance dashboards, so problems are spotted and fixed fast. Okay, so this is sort of like our final slide. The 5 high-level steps that I just described are complemented in the guidance by more detailed considerations that fall within these 10 areas that you can see. I will summarize what each consideration include, and as I mentioned, please see the guidance for more details, and there's quite a bit in the appendices. So the first area is around risk identification and assessment, and what the ask there is to complete risk, safety, and data protection assessments, and just to ensure that your suppliers meet relevant standards like the DCP 0129. Then around regulatory compliance, that's about determining if the product qualifies as a medical device. And I've just mentioned that, we developed that section in collaboration with MHRA, and it will be updated soon. Then data compliance and security is about engaging early with your IG and cybersecurity teams, just to ensure compliance with UK GDPR, and also with the data security and protection toolkit. Integration and performance is about, defining your integration needs in relation to your electronic health record systems, and then, setting clear performance expectations. Portability, scalability, and flexibility is about choosing systems that support what it says, data portability, and that they can scale and adapt to future healthcare demands. Support and maintenance is about planning for long-term maintenance with clear service level agreements. Supplier engagement and procurement is about clearly defining your needs at first, and then what is recommended is to use accredited NHS procurement frameworks to ensure compliance. Then monitoring and bias mitigation. This is about continuously monitoring the product's performance and addressing potential biases, especially in speech recognition across diverse user groups. Perhaps I should pause here as well, even on some points that Joyce mentioned previously. It is important to acknowledge that any AI can have biases. For example, ambient scribes as well. For example, struggling with certain accents or dialects. So the guidance explicitly advises checking that the product works for different accents and dialects, and monitoring as well for such users. Different patient groups may also react in different ways in relation to the use of AI and ambient scribes in their care. So it is important to be transparent, but also monitor whether any patient groups may hesitate to seek your services due to these products, or any impact of the dynamics and the quality between those patient professional interactions due to the presence of ambient scribes. I guess the key message here is that the technology should serve or patients equitably, and any problems in that regard should be actively managed rather than sort of put aside. Okay, now back to the 10 areas. The ninth one is about user training, which again is quite an important one. That's about providing training on the effective use and reinforcing the need for practitioners to review and validate AI-generated outputs. And then finally, the last one, under liability, you should note that NHS organizations may still be liable for any claims arising out of the use of AI products, and there's more detail on that in the guidance. So I will just stop here as this kind of high-level summary of the guidance, and I guess the message to leave you is that with ambient scribing products, they do have potential to be transformative, but we do need to implement them safely and compliantly with robust human oversight, and the guidance is there to support along with the forthcoming documents that I mentioned. Yes, happy to take any questions.
Fantastic. Thank you so much, George. Hugely comprehensive and really helpful to have that last slide that breaks down each of those different steps and considerations. So there are some questions I can see. So there's one in the chat already from Chris Weevil. Have any of the trials delivered efficiency benefits, good return on investment that you are aware of? My thought is that a lot of the discussion is around extra auditing, extra assurance processes, and it feels like time, effort saved may be consumed by these extra assurances.
Yeah, no, that's a good point, and it's definitely something that we want evidence for, and we want to capture in sort of like our ongoing monitoring of these products. So there is a number of studies. There is even some published articles to kind of support the transformative opportunity of AVTs. And I mentioned the study that the Great Ormond Street Hospital are leading, which is a multi-site trial, and it's been done with over sort of 7,000 patients across primary care, community hospitals, and sort of mental health trusts. So we are expecting the official numbers from that trial within a month, and hoping to share that, so that could help others in sort of like building that case and addressing some of these concerns. Yeah.
Fantastic, thank you. Can't wait to see the outputs from the Great Ormond Street work. Bob, you've got your hand up. Bob Weller.
I was just going to ask a question about that last slide, really, because you've not really mentioned evaluation. I don't know whether it's implied through the monitoring and bias mitigation aspect of it, but some of these devices, in my experience, they don't work, or they don't work in certain settings, certain environments, certain populations. So where does that fit in?
I mean, I would like to take this conversation with you, Rob, as well, just to understand sort of your insights around where you think it doesn't work. But part of I guess the approach that we are expecting settings to follow is to understand the type of impact and the benefits that these technologies can have, and also part of the existing trials and the evidence that is being captured is around that. So, we do want to make sure that these products can provide benefits for everyone and in each setting.
Chris.
Just a follow-up question that's come up in the chat from Simon at Burnbury Medical, mentioning about GP practices having access to a level IT support. Obviously, the guidance is really comprehensive, but there is an element where it says, if you're stuck, contact your ICB digital teams or your ICB teams. Makes sense, but obviously, as an ICB digital team, I'm going the way of the dodo by October. We've been eliminated in the model ICB blueprint, so the guidance is going to have to potentially be tweaked to sort of forward that along. But the point there about clinical safety officers and IT support for primary care is a good point. Do you know of any support out there at a regional or national level to help these people out? And actually to help us as ICB teams out while we're still here?
So, I mean, obviously, this is something that, and I did mention that the guidance is iterative, but that is a good point, and it's something that we need to monitor and understand in terms of how best this support can be provided to primary care. There is a program of a broader program of work that is looking into capturing sort of the requirements and capabilities that are needed to scale ambient scribes across the NHS. So this is something that we need to take into consideration. In terms of IG, there is within the guidance sort of a contact to clarify some concerns, like a central contact for the IG team to clarify for some of those concerns. Yeah, we're probably looking into clarifying further within the next iterations of the guidance, perhaps specifically around IT as well.
Thanks. Really helpful to know that it's iterative and to keep referring back to that. And presumably, will that be well communicated out, or do we just keep coming back to the NHS England website to check for updates?
So the updates will be published in the link that I would just say, but we do intend to also continue our engagement and communications, particularly with some key networks like the CIOs and their the meetings that they have. Yeah.
Thank you. So another question in the chat, if that's okay, George, from Amanda. Is there any evidence on patient feedback on their experiences of consultations using Ambient AI, particularly around non-clinical settings?
So as I said, this sort of feedback and evidence is being captured as part of several trials, and we are looking to sort of publish them when it's sort of packaged in a way. I think what's important to I guess reiterate again is and what the guidance as well makes clear is to ensure clinical safety and data sort of security, which I guess addresses our responsibilities towards patients, but as well as Joyce said, to sort of continue engaging with patients and sort of like understanding their perspectives. So I guess what I'm saying is like, it's important to understand that it's through research and trials, but it is an ongoing process as well of sort of getting patient feedback.
Thank you. Another question in the chat. From the trial, what were the risks identified in terms of output from generative AI, for example, hallucinations and so on?
Yeah, so the risks, which you can sort of like see as well a little bit in the guidance, there's some safety risks around accuracy, as you mentioned, so potential errors in the transcription, especially when it's kind of complex clinical terminologies or as I mentioned, some sort of speech conditions. There's also as well contextual understanding, potentially misinterpretation of the clinical context, which could lead to sort of like documentation errors, as well as completeness. So, making sure that there's no gaps in the documentation that could compromise sort of patient care. If we look at sort of like the broader concerns, it is also about data and cybersecurity risks. So, potentially data leakage, in terms of the integrity and confidentiality of user data, and that's why we have the processes that we encourage. Then, of course, there's regulatory compliance, which is based on the intended use, and that's what we're trying to clarify. Bias and performance that I mentioned, there could be bias in outputs, and that's why ongoing monitoring is sort of required. So there's several risks that can be understood as part of the risk assessment process and standards like the DCB 060 and the data impact assessment.
Great, thank you. Any final questions from the audience? I can't see any hands up, but please do shout if I've missed you. Otherwise, just to flag a comment from Jason Patrick, who's highlighted that they're on their third pilot, but highlighted a return on investment is 70% reduction on working through lunch, evening to catch up over time. So benefit for clinicians' wellbeing versus the financial savings, which absolutely kind of speaks for me to the heart of why this is the opportunities here are so huge. Jason, I don't know if you want to say anything more to that, but thank you for sharing that experience. In which case, we've come to 10:45. So, George, a huge thank you for your time this morning and for the really insightful, comprehensive presentation. I'm sure everyone's found it incredibly helpful. So thank you for the time. And we will share the slides after the event. So a huge thank you.
Thanks very much.
Thank you. So that takes us on to our next speaker, who's going to talk to really the questions that were flagged around kind of the support for primary care and the steps that are needed to go through when adopting ambient voice technology. So I'm going to invite Dr. Mike Smith to speak and to introduce himself fully at the start. Mike, I can't see you on the screen, but I'm hoping you're there. Oh, here we go. Yes, fantastic.
Hi there. So I'm going to share some slides, which hopefully will show for everyone. It's failing. So yeah, I'm Mike Smith. I'm a GP, but I'm also one of the Associate Chief Clinical Informatics Officers in the Northeast and North Cumbria ICB. So going the way of the dinosaurs, Chris said. But for now, trying to do what I can, what we can to try and support these sorts of endeavours. Now, the points Chris and Simon have raised about primary care has been a big concern of mine, not least because I am a GP myself, and have seen lots of practices going ahead with ambient tools, often without the recommended approach that George has highlighted above. And I think the recommended approach is very what's the right word? It's very heavy, but it is necessarily heavy because this is a really novel technology. And I think it can be distilled to a slightly more manageable level. My personal view is that there is a lack of support for primary care in terms of IT support and expertise in this area. And one of the big challenges for primary care is that really to safely implement technology, you've got to be within that environment. So being an external person jetted in to say this is how to safely do it is very difficult because you don't know the intricacies of that practice. So the way the systems are designed and where the guidance is designed is on the basis that the clinical safety officer, the expert who's supporting this, is actually embedded within the organization and is a clinician who works in that organization. So in a way, in a general practice environment, that does get very difficult in a very small practice. Thankfully, with PCNs and larger practices becoming more common, it's likely that there will be somebody with the skills, interest and expertise to get involved. So this is my attempt at distilling the DCB 0160, the terribly named clinical safety guidelines. that are recommended to try and make them more approachable and manageable. So I'm going to focus on that element. I'm not going to go into the GDPR side of things and the requirement for data protection impact assessments, as they're I think most practices will be familiar with those, and most people will be familiar with those, and it's a slightly separate thing. It's more about the data risk. I'm going to focus more on the clinical risk. So here we're looking at how we can make sure the tools that we're using, in this case Ambient, is safe and effective and not putting patients at risk. So like I said before, the way the guidance is written in law is that essentially this is the responsibility of the implementing organization, and therefore a clinical safety planning process needs to be done by that organization. ICBs can provide some technical advice and support where there's resource to do so, and as was already mentioned by Chris, the resource is limited, but they can't really do it for you. They can't sign it off. It just doesn't work that way, and it can't work that way. But as I say, hopefully as I go on, I can demonstrate that it's not as hard as it sometimes is articulated to be. So the first things that you need to be doing, and this was articulated in a letter from the National Chief Clinical Informatics Officer, is that you need to be asking for a DTAC, which is a digital technological assessment, which is something that any vendor should be doing. So this, the likes of Tortus, Heidi, Accurx, they should be producing a document that is available and can be easily sent to you as a user, that you can go through and check that they've done the necessary bits and pieces which are articulated in that letter from the national team. And that includes a DCB 0129, which is the clinical risk assessment done by the vendor. And then there's the other issue around medical device. Now that is its own complicated area. In essence, as an average general practitioner, I think it's reasonable to trust that the vendor has made an appropriate judgment on the medical device status. But if you get guidance to the contrary, then it's your responsibility to challenge the vendor on that. Then it comes to the bit that needs to be done in the practice or in any organization, which is a DCB 0160. So the key outputs of this, the reason this is useful to me as a GP and why I think it's important to do in any organization, is that you're identifying in advance of implementing the system what can go wrong, what are the hazards, what might befall you or your patients if you use this technology. And by thinking about what the hazards are, you can then think, how do I stop that happening and stop you ending up in a pickle down the line and your patients ending up harmed because you've implemented it in a way that's less safe. And with a novel technology like Ambient, where it's using AI that is poorly understood by the general population, both clinical and non-clinical, and the patients, it really is important to think this through before you go and start using the tools. The next bit is then also to then articulate what those risks are. So what risk is your organization taking in implementing this? Compare those with what are the benefits, what are the upsides, and with Ambient, as articulated already, and I'm sure later in the day, there's lots of those. So you're then weighing up risks and benefits, just like we do with many decisions in practices and clinical environments, and say, is it worth the risks to have those benefits? And oftentimes the answer will be yes, but it's important that those who are approving it, for example, GP partners or trust management, they understand what those risks and benefits are. So they can't then be held, if something goes wrong down the line, it doesn't then befall on an individual person that they say, well, you didn't tell us that this could go wrong. So it's really important to get that out of the way in advance. Now, this is my summarization of the national guidance. The national guidance is lengthy. They are looking at improving it. It's about 70 pages at present, and it's written in a relatively technical language that's not super understandable to me as an average GP. It took me a long time to get my head around it. But broadly speaking, these are the key points. You need a clinic, and I'll go into this in a bigger screen so you can see what's written there. So the first thing is, do you need to do it? And the answer generally with something like with any digital technology that's involving patients, the answer is yes. It's written in the Health and Social Care Act of 2011-12 that it is a mandated part of clinical practice. And the next bit is you need to have a clinical safety officer. So this is a clinician who has done some training and understanding how this works in terms of doing a safety process. And they also are then ultimately the ones responsible for making sure it's clinically safe. So it's a named clinician who is going to do that. So as I mentioned in this slide, our regional CCIOs, the likes of myself, can provide some support, but we can't be that clinician because we're not embedded within that organization. Next is a hazard log. So I've been developing a tool, which I'm going to quickly share to try and make this a bit easier, because at the moment, mostly everyone uses massive spreadsheets that I personally find utterly unusable and very challenging to navigate to try and articulate what the clinical risks are. So I'm just going to try and but actually what you're doing is a very simple process in identifying hazards and risks. So I've developed an open source tool that is available as a link in the slide. And it's still under development, so not quite ready for action yet, but I can demonstrate this part of it just so people understand what it does. So what you're doing in a hazard log is you're identifying what could go wrong. So for AI Scribe, some of the key ones are it could incorrectly summarize a consultation. You could end up entering data into the wrong record if you're copying and pasting between windows. You could fail to gain informed consent, and that could lead to patients not being very happy, shall we say, if that occurs. So when you're thinking about it, I'm going to add another one that we know about, and that is software being used beyond the intended function. So for example, a user decides to type in, please give me a differential diagnosis for this consultation. That's not what the software is designed for. It's not been safety tested for that. It may make lots of mistakes, but it may do it. So a user could potentially do that because it's very difficult to put full guardrails in place within the software to prevent that. So then you've got to think about why might that happen? That might be because the user adds the custom prompt as I've just described. And then you want to think about what can I do to stop that? What can we as an organization do to prevent that? And in this case, it would be making sure we're training people, telling them that this can happen. Yes, you could type that in there, but don't, because if you do, you may get useless information on the other end of it that may lead to a patient becoming harmed. So one of the key things there is we're going to need to we'll recognize that cause, how we can mitigate it. We then need to think when you're doing a hazard log, you think about what could be the impact if that happened. So if a user goes ahead and does that, and it could lead to an incorrect treatment or incorrect advice being given. Now, what level of harm is that going to cause is then the next question. So how bad could that be? So in this case, it's probably a major level of harm in that it could cause death. Worst case scenario, the wrong diagnosis is made, the wrong treatment is given, the patient becomes more unwell. It could happen. There's lots of other more likely outcomes, but that is definitely the worst case scenario. So then you think about that worst case scenario, and if that was happening because of this hazard, so because somebody puts in the wrong prompt, and you put in the mitigation, so you've trained people, how likely is it to happen? So you've told your users don't do that. It could still happen, and if it did happen, it could lead to death. So how likely is death likely to occur, given that you've told people not to do it? But it could happen. So in this situation, you're going to say that's probably pretty rare, because you'd hope that nobody's going to do it anyway. And even if they did it, it probably wouldn't lead to death. It probably wouldn't lead to any bad outcome in most scenarios. So therefore, you then get a calculated risk rating, which is used from a risk matrix, which is provided in the DCB guidance to say that that's generally considered to be an acceptable level of risk. And then you get your levels of risk for all of the different things that you've thought about. And then you can articulate that to your board, to your partnership, to say this is what risks we anticipate after having mitigated them as best we can. And then you need to think about and then what that spits out is your mitigations. So your mitigations then essentially become your training package, because training is one of the key ways you mitigate a lot of these risks. So by thinking it through carefully and getting to that point, you can get a list of things that are probably going to go wrong and what you need to tell people about, and you can choose to mark that you've done them, and you then understand where you're going. So we did that in our ICB. We provided as a template to practices as a starting point, and you end up with a very simple training package which talks about how the tool works. Things like if your microphone doesn't work, the transcript quality will suffer and things will go wrong. And then you end up with a really relatively simple training sheet that people can work through and practically minimize those risks and make those risks tolerable and manageable. I'm going to go back to my main slides now to talk a bit more about where you go from here. Sorry about having to switch between screens. So we talked about, so that's the risk matrix that I was referring to there. So where you compare the likelihood versus the severity of an impact. At the end of all that, you produce a safety case report as the final step, which basically you articulate what you're trying to do, what the purpose of this ambient tool is, description of how it's going to work, talk about the governance, i.e., we've done this process, we've got a clinical safety officer. These are the key hazards and levels of risks and mitigations. What are the alternatives? I always think it's really important to think about what that alternative option is. If you're going to do this, this often ends up looking really bad. Like we've looked at a load of things that could go wrong, and then the natural inclination is to go, well, we shouldn't bother. Definitely bad idea. This could all go horribly wrong. But actually, the alternative could be just as bad. Clinicians spending hours at their desk doing documentation, and the documentation quality being subpar, lots of typos, potential errors, burned out clinicians making bad decisions is itself dangerous. So then you've got to weigh up the risks of not implementing it with the risks of doing so. And it's really important to look at the upside as well as the downside and not just focus on the bad stuff. And then you ultimately, the clinician, who is a clinical safety officer, on the basis of that, they make a recommendation on whether they think that is a tolerable level of risk and whether we should go ahead with the process. So that's essentially what you do. Then you take it to your board leadership and say, can we go ahead with this? Is this a good idea? If they say yes, you then review it on an ongoing basis, update your hazard log if something goes wrong, so you can keep tweaking it and iterating, as I think most of us do with any new process. So that is a very quick description of what needs to happen. Now, I appreciate that most organizations lack the expertise at present to do that. I'm talking primary care organizations, but it can be achieved, and I think it is achievable. And actually, when articulated that way, it's not, most of the stuff that's in there is being done, it's just not being written down. People do think about that when they implement processes, but perhaps following that structured approach just makes it a bit more likely to encapsulate everything that could go wrong and how to mitigate it. So I've used some Ambient Scribe, so I've got some personal reflections to talk about. I'm just going to come out and get to my notes. So the first thing I would probably say is I've felt that patients are very open to the idea. When, openly consenting patients each time, it does open the conversation sometimes, and patients talk about it, and they generally are wanting to see the NHS innovate in terms of productivity and be more efficient. So patients generally, even about mental health problems, which are very private, are generally very open to the idea because they recognize there's going to be notes taken. People are comfortable for the most part with digital technologies if they're safely implemented. So I don't think my experience with patients is that mostly when it's properly explained and understood, they appreciate that you're trying to do best for them and they're supportive of it. But it really is important to get that open consent. And some patients don't consent to it, and that's absolutely fine as well. And that's why that open consent process is really important. The other thing I feel like is the notes that are produced by the Ambient tools are likely to be a lot more usable for patients than my old hand-typed notes, which are full of abbreviations and typos. Patients use the NHS app a lot, and they're looking at their own notes. Having them readable improves clinical safety in the long term because patients could refer back to them if they didn't gather all the information in the consult. There's lots of studies that show patients don't take everything away from a consultation with them that a doctor or a nurse or another clinician recommends to them. So them being able to read it themselves in a readable form is really important. And I guess I've got one negative reflection, which I think is just something each to their own, I would say. But I personally find the Ambient consultation notes not hugely helpful as a clinician for continuity. I find that the act of either dictating or writing up a consultation cements in my memory what happened during that consult. And when I've used the Ambient tools, because essentially AI is doing it for me, I don't then go through that process of having to re-articulate the consultation in a note form and summarize it. And the lack of that cognitive process means that my recollection of what happened is not as good when I next see that patient, which is definitely a downside. But as I mentioned before, with these technologies, it's all about weighing the upsides and the downsides. And for many clinicians, while they may experience that downside, it may well be worth it for the benefits that they're going to get. So with all of these things, you're weighing up the benefits and the disbenefits and some of the financial costs as well. But it's important to put all of those pieces together. Anyway, I share those brief presentation. I'm happy to take any questions.
Thank you so much, Mike. That was incredibly helpful. I was really struck by the fact that you talked about teams being really aware of the risks and mitigations, and everyone having that shared ownership of that, so they're aware of the risks, but also that the current standard of care might be worse, or as good as the innovation that's being brought in. And actually, we quite often forget about that, don't we? That the current standard practice might not be great, and you're not always comparing kind of like for like. Thank you for the personal reflections. There's one other thing I think you were going to talk about, which was TPP's acceptability or not. And I just wondered if you want to say a couple of words on that before we move on to the next presenter.
Yes. So TPP issued some guidance. I think it was either early this year or end of last year, which stated that they consider any use of robotic process automation software on top of their technology to be a breach of their contract with the practice or the user of that software. So the question is whether this falls into that category or not. Now, I'm not a legal expert, and TPP would ultimately form their own opinions as to whether it is or not. But for some of the technologies, they're using the IM1, the official integration with the System 1 system, and that isn't using robotic process automation at all. So that's not likely to be affected by that. That is a recognized integration into the system, and there are agreements between the Ambient tool provider and TPP to support that use. So that wouldn't likely be affected by that. Other tools use a copy and paste method into the system, which again is not robotic process automation. So that is not likely, again, in my opinion, to affect things. Where it would affect things is if it's essentially scraping data out of TPP or automatically putting it in via some robotic tool, some sort of software to automatically put it in. That's not an official integration. So you need to just check with the vendor to see whether that's their method and whether that might put you in contractual breach with TPP.
Fantastic, thank you. Really pragmatic advice. So questions that can be asked of the suppliers later today. We will have time for questions, but I'm going to ask Dr. Andrew Noble to speak first, and then we'll have questions for both of you, if that's okay. But huge thank you. So next presentation is from Dr. Andrew Noble. Oh, fantastic. I can see slides coming up, so I'll hand to you now. Thank you.
Hi, thanks very much for asking me to come and talk as well, Laura. So I was asked to come and talk about our experience of introducing an AI scribe, and basically talk about some of the issues that also may have arisen in doing it. So whilst I'm going to talk about some of those, I would actually say right at the beginning, I did speak to some of my colleagues the other day and suggested what would happen if we took this away now, which was met with consternation and upset. And I think it is certainly something that has been very game-changing for us. It's certainly changed the way we do things, the way we take notes, the way our notes are presented. And actually isn't something that we feel we could do without now. So it's just worth saying that at the beginning. However, we have met various hurdles and things along the way, and it'd be, I think, useful for everyone to hear what those sorts of things might have been. So this is about our journey. So I'll give you a bit of introduction and context at the beginning. We'll go through sort of what the actual challenge was, which is clearly the documentation burden. Then what the sort of hurdles were in sort of getting to the beginning. Then we'll talk about our pilots, particularly how that informed our training, and then how we've sort of continued working with the technology, particularly around how we develop our templates. And it's really, I think, be helpful to hear about some of the impacts that's had on patients and staff, and then a few thoughts about evaluating this for the future and the sort of continued evaluation as we go on. So a bit of an introduction. So I'm Andrew Noble. I'm a GP with an extended role in frailty. In fact, all my work really nowadays is around frailty. And within our frailty team at the Jean Bishop Centre, I'm the lead on education and training. And I've somehow adopted this lead around digital health. which I think goes to the geekiest person in the team. So I don't have any qualifications, I think, that lead me to have that. I'm just very interested in it, and have led on various other areas of digital health. So the AI scribing sort of fell to me. I work in in CHCP, so the City Healthcare Partnership. And as I say, the context of introducing this AI scribe was around frailty. So we're talking about patients, sort of older patients who are very frail, in lots of different healthcare settings as well. So not just in the Jean Bishop Centre, patients in their own home, and patients in our community bedded units, and also a lot of work over sort of urgent community response or over the phone. So this is just our journey going through all of that and how we introduce this. So the initial challenge, and this is the challenge that AI scribes are trying to improve for us all, was the documentation burden. And in effect, I suppose when you look at our work streams, in some areas, we are spending 30 to 40 minutes writing up notes. So if I'm seeing a patient doing a comprehensive geriatric assessment, I might see that patient for an hour or so, but I'll spend another 30 or 40 minutes writing the notes afterwards, putting the care plans together, doing the referrals that are related to that consultation. So we had a little look at what we were doing in the work streams and looked at the ones with the heavier documentation. And as I say, we came up with 3 areas, although we do use it across all of our areas. But the comprehensive geriatric assessments was one, urgent community response was another. So there's quite a heavy workload in that area. So it's a bit like general practice. You're seeing patients sort of one after the other over the phone, offering advice to other healthcare professionals. And they can last, those consultations, anything from 10 minutes to half an hour, often with lots of things to do afterwards. And the documentation for that could take anything from 5 to 30 minutes afterwards as well. And then we looked at our hospital at home, which is our virtual ward, how we might use the scribes in that sense as well. So yeah, so what were the hurdles in doing this? Well, the initial thing, we looked at this back in March last year. So this was just when people were starting to think about AI scribes. And in particular, when none of the AI scribes, I think, had really gone through the NHS sort of processes in looking at the data protection, all that side of things. So in fact, the first thing we did was to contact our own IM and information governance teams to sort of say, well, how do we go about this? How are we going to start using an AI scribe? And the first thing we had was that we had a lack of an AI policy within CHCP. So that had to be addressed in the first instance before we could go any further. And also all the GDPR compliance, all the stuff that's been talked about prior to me talking to you, all that stuff that the companies were still going through. So that process was going to take a little bit of time. So there was a time between April and end of July where all of that stuff was being put in place. So we had a little bit of a gap there to wait before we could do anything. So we had our AI policy established. We had a clinical safety officer who we actually buy in at CHCP from another company, but they were very useful in setting this process going. I think it might be one of the first times they've gone through a kind of AI technology and the sorts of things we should be thinking about. But certainly as clinicians, open our eyes to a few things that we hadn't been thinking about before. We had to get through, say, our governance committees and thinking about how we safely implement AI scribing, and particularly as this hadn't been done at this point anywhere else, or at least was only just being started, everyone approached us very, very tentatively. And I think a lot of the risks that came onto our risk register, it would be nice to see that. Actually, Mike, I was really interested in your in how you sort of put together your hazard log, because ours is just a massive spreadsheet, which is really difficult to navigate. But there were lots of things in there, even thinking about what happened if the Wi-Fi went down, and what would happen if in various instances where hallucinations were taking place in technology. And we hadn't really, I suppose, used it properly yet to really understand all of that. So we then embarked upon what we called our pre-pilot, which was just a chosen set of clinicians to work through for a month, starting to use the technology to try and understand what some of these training needs and hazards and things were going to be. So we very sort of tentatively and carefully sort of introduced that. The other thing we needed to think about was around sort of patient consent and how we actually went through that in our systems as well, because one, making sure that patients are consented, but two, also being able to trace back where we've actually used the AI tool in the system, because of the auditing processes we had to put in place in order to look at the notes and be able to go back, take a sample of notes and look to see if there were any issues that there isn't there. So we did our sort of pre-pilot, and as I say, this was just a small group of us who basically tentatively introduced the technology into some of the work streams. It allowed us to start thinking about the sorts of things we needed to talk to staff about in the training, which I'll come to in a minute, and therefore allowed us to identify the training needs for the whole team. The other thing I want to point out on this slide is we decided we'd do this as a phased rollout rather than just giving it to everyone. I have seen some organisations just giving it to everyone and sort of see how everybody uses it. But because we're a multidisciplinary team, we needed to understand how each of the disciplines within that MDT would be using it as well. So we did a sort of very much a phased rollout over a period of about 4 months, bringing different parts of the team into that at any one point. And then we made sure that everyone who was using it before they got a login, they had to have attended the training, which we initially recorded so that everyone could do that, and then they'd get their login. And then I have to say, it's the most popular training session I've ever done in our organisation was when we introduced AI scribes. So the first thing we brought up, and the thing I wanted to underline a bit, was actually starting off with what the limitations of the AI scribe were, because there was a feeling amongst the team that, oh, this is going to be brilliant, everything will just be done for me, it's instant, bang, goes into the notes. And I think actually breaking that understanding in the first instance was really important, because clearly you get hallucinations. Clearly most of the notes that were produced need a little bit of tweaking and editing from us. And unless you actually prepare your team to do that, the first time that happens to them, when they look and say, oh, that's not quite right, or it's got that wrong, or the context of this isn't quite right, they abandon it because they don't understand what their role is now that we've introduced the AI scribe. And actually that role shifts from being somebody who is writing lots of notes and putting things together at the end to someone who is checking a set of notes, making sure that the context is correct, and then putting those notes into the patient's electronic record. And actually Mike was talking about how he was concerned about his sort of iterative processes of, you know, what he'd normally do is he'd write a set of notes and that would help him to form his sort of management plan as he went. And I have to say that was my concern initially as well in doing this, because I use that process cognitively to help me sort of pull things together. But actually I found I very quickly adapted to being the checker, and actually that process happened in that time. So as I was checking the notes and going through, I was formulating various thoughts and plans around that, and maybe therefore making tweaks at the end. And I can definitely say that the scribe that we're using over time has actually got much better. And I don't think that, I know that's not because they're actually looking at our consultations and how we do things, because they don't do that, they don't take that data to do it, but it's actually because their training in the background is getting better for the scribes. So certainly the technology is sort of continuing to improve all the time. We talked to staff about consultation management, because some of the issues here were things about multiple people in the room. So you imagine if you've got a couple of patients in for comprehensive geriatric assessment, you've got a patient, sorry, and a couple of relatives. They do like to join in, which is great, and the Scribe's pretty good at sort of deciphering all of that. But sometimes you'll have a relative talking about what their medication list is or what things they've had going on, and that can sometimes get picked up into the patient's sort of list as well. So you just have to be aware of that and sometimes manage the consultation a little bit in that sense. Busy rooms, so our UCR room is quite a busy room. There's 5 or 6 people in there, often on the phone, some of us with quite loud voices. And occasionally you will find that there's some crossover as well. So we're actually looking at our room setup and how we can sort of dampen down the echoes and the sounds a little bit to try and improve the note taking there, but certainly making people aware that these things do happen and you should be sort of looking into the note for that sort of thing. The templates, we talked a lot about how we use templates in our different workflows and work streams. And actually with the staff, although we weren't particularly training the staff themselves to make the templates, a small cohort of our staff did need training in creating those, because what we've tried to do as an organisation is have a standard set of templates for the organisation, and they have to reflect to the templates that are in System 1, which makes it a tiny bit complicated. And in fact, we have had to manage our templates in System 1 a little bit, because the AI Scribe actually now starts to construct the structure of our consultations for us, so we can actually paste into less boxes. But at the same time, we have to keep recoding all the things that have been going on normally through the way we take our record our electronic patient records. So it's a bit of a we've had to sort of weigh that up a bit and try and make that work. Hopefully, integration when that comes will help to solve some of those issues. And again, there were some technical things we needed to talk about. Initially, we were using it through the web, but the AI tool then developed a desktop app and a phone app, and actually it's just keeping staff abreast of how those things work. So all of those things went into the training. As I say, people then went away to start using the tool. So I talked a little bit about working with templates. Actually, I might just skip through this section a little bit. It's really, I suppose some of this is just when you start to understand the structure and the way that the templates, you can create templates in the AI tool, it does actually feed a little bit into how you then operate your templates in your electronic patient record. And I have to say, so anyone knows anything about large language models, the template that we're talking about here in the AI tool is literally a prompt to the large language model that's working off the transcript that's been created, to therefore create whatever you want out of the AI tool. And for us, for instance, I can create 3 or 4 pieces of documentation out of one transcript, which is what I'd normally be doing at the end of a consultation, but typing them all separately. So it saves an enormous amount of time in doing that. We had to think about a few other issues here. So we did a full audit of our notes before, and then we've audited our notes afterwards, and we're about to go into what's a third audit now of our notes to check that that what's being recorded, what people are actually pasting in from the AI tool, is actually still meeting our sort of standards for notes. I mean, essentially, as people probably expect, the AI tool has increased the standard. We've had pretty good standard of notes, to be fair, but it has increased it, it's improved it. It's half the amount of spelling mistakes in there. The only spelling mistakes in there now are the edits that we make in the actual AI note, and it's reduced the amount of abbreviations that we're using, and it's structured no better. There's things that are included in there because of the templates we apply, which people weren't always recording, like who was present in the consultation, what the full follow-up plans and things might be. So the note's much easier to read, which I think is obviously sort of safer in the long run. We're incredibly, well, the policy and the AI policy we have is there's always a human in the loop, and I think that's with all AI scribes anyway, and with the NHS England guidance as well, needs to be a human in the loop. And in particular, a lot of that, I think, for me anyway, is about sort of that cognitive thing about checking the notes and making sure that I've got the same management plan in my notes as come through on the tool itself. I'm aware that we are a bit pressed for time, so I'm just going to move through to a bit of the impact on staff and patients. We have a really nice patient group at CHCP. They're always very keen to speak their mind, to tell us exactly what they think, which is good because you need to hear those things. And we took this to them before we actually went to the live with this, asking what they thought might come up, what sort of concerns they might have. No one was particularly concerned about the AI component, to be fair, but they were worried about things like accessibility for patients. And until we explained fully how the technology worked, they were worried about patients with disabilities or of different languages, etc., might not be able to sort of access the tool. But the biggest concern that they had, which I'd not even thought of, and was actually the name of the tool. So we use Heidi, and they probably won't thank me for saying this, but our patient group was concerned that men would feel excluded because they had Heidi listening in the background to them, and that they might feel that they couldn't sort of talk about these things. Well, to be honest, I don't use the name Heidi. I just say, oh, I've got an AI scribe. So that hopefully that hasn't arisen for anybody. But I think it did. Obviously, it changed the way I presented it to patients, rather than saying I'm using an AI tool called Heidi. I have fed that back to Heidi, but I don't know whether it's a huge problem, but certainly that it influenced the way we presented it to patients. So I think, again, one of the other things I've just put at the bottom of here is reviewing outputs, which I've actually just started doing because I heard someone else was doing this, and actually talking through the output with the patient at the end. Actually, before I would just summarize what I thought was going to happen, and as they left, I'd put the scribe on and see that the scribes captured it all. But now I actually get the patient to sit in the room with me when we're doing a face-to-face consultation. So, well, let's see what the scribes thought of all of this. And I go through the plan with them from the scribe. And I found that really helpful. I think patients have found that really useful as well. It takes a while for our longer consultations for that to happen, but certainly in smaller consultations, I think that's a real benefit of these. And I think particularly when Mike's mentioned about patients checking their own notes now, if they've agreed an output with you before they've left, then when they go back to look at their own notes, then maybe that may be much better for things like medical defense purposes and stuff in the future. Although it might take up some of the time saving in actually creating a note with the AI. Impact on staff. Someone mentioned before, I think in the chat, about saving staff saving time writing stuff over lunchtime or writing their notes at home. The biggest thing that came from our staff was actually, oh, I've gone home on time. It wasn't so much about increasing productivity, seeing more patients. Actually, I managed to get home on time, and that was really important. But we think the time savings in note taking are about 30 to 40%. Certainly from our initial pilot, that was the case. And we're actually now following this up with a much bigger study, which has been led by University of York, actually, in the health economics team. I can't remember their full title. But that's going to look much deeper into the sort of cost benefit side of all of this, and how much time we are actually saving. But certainly for us as a team, the one thing we've done from this is for years we've been trying to introduce protected learning time for our team, and actually it's been really hard to get the leverage to do that because we can't reduce the number of patients that we see. So what we've actually done is we've now introduced afternoons where we have protected learning time for the whole frailty team, and because of using the AI scribe, we can see and make up the deficit in, as it were, in patient numbers on other days. The team are quite happy to do that because they know they've got that increased sort of productivity in the background. So we've actually been able to set up a whole learning sort of education sort of experience for our team, which is actually 2 protected afternoons a month. Which is already, that started a couple of months ago, and that's already having a benefit to the whole team. So evaluation, the impact and future directions. Well, I've just mentioned that we've got another study. In fact, I had a meeting about that before I came here, which is starting in July, and that's actually that's going to be looking at not only the qualitative stuff, but also trying to dive into the sort of cost benefits, sort of implications, even looking at what areas, which staffing areas benefit more from it, although my experience is that they all say they do, but it's looking to see what the savings are from that side, and actually look at what the time savings are, drill that down as much as we can. It's sometimes really hard to pin that down. It feels like you save time. I definitely save time, but actually getting a figure to that and trying to sort of put that out there as well. So we'll be able to make that available once that's been done and finished, which will be around about October time. And then Laura just asked me to put a few things on here about what would we do, what are the key takeaways from this in the future. Make sure, don't just offer it to staff. I think staff training is so important with this, and I'm sure everyone else on this call would sort of agree with that, but put some of those things in that we've been talking about already, about what the AI tool, that it will do things like hallucinate, and it will sometimes make inferences, and no matter what the manufacturers tell you, it does happen with all the tools. It clearly is improving, but it's really important to put that in there and outline the staff's role in putting that, in checking that, putting in the notes, because it's their responsibility when it goes into the notes for that consultation, for that particular consultation. Get IT and governance IG in there early. because they take so long, because everyone has lots of meetings and things. But I really feel like we could streamline our processes much better, I think, to get these things moving. Because one of my concerns is that we're going to start get driven by the AI technology rather than drive the AI technology itself. And I think as an NHS as a whole, we need to get much better at evaluating safely. But actually, I think we can evaluate things faster if we streamline our processes a bit better. So thinking about that really for the future. And yeah, just note that this stuff is evolving, and the stuff that's around the corner sounds amazing, but we're going to need to know how to evaluate that. But I'm really keen to see how things like AI summarization, that kind of stuff, starts to develop, because I think that'll have huge benefits to us if introduced safely. I think, Laura, that is my presentation. I'm sorry if we've gone over a tiny bit.
No, it's fantastic. Thank you. We could have listened all morning. It was absolutely brilliant to hear kind of how it's gone in practice. You obviously are a real forerunner in terms of the adoption. I really thought it was fascinating what you were saying around ensuring that all staff had undertaken training before they started using it, but also the kind of clarity on the limitations of the AI and ensuring that there was that human in the loop throughout. And just wonderful to hear about taking the patient through the write-up that has been produced by the Ambient Scribe. Absolutely fantastic. Thank you for sharing. We are running over, but I know there will be questions. So let's just stay on for a few more minutes in case people have questions, either for Andy or for Mike. Yeah, this is a great opportunity to pick brains about people who are kind of living and doing it already. While people are thinking about their questions, some great comments in the chat, particularly around the kind of the regulatory piece, the fast nature, evolving nature of this technology, and how to approach kind of some of the practical pieces around the kind of the hazard and the risk logs. But any questions?
I was going to say, look, just an interesting, just it's worth just explaining how my day operates around AI, just very, very quickly. But so I did home visits on Tuesday for some of our very housebound patients with frailty, which again, hour-long consultations in the home. And I actually started off the day by creating a note for them all on the AI tool, which was me dictating in all the information and stuff that I knew from their medical notes, putting together a kind of my thoughts about things before I went there. So that I already had a note sort of created with a lot of context on it. When I got to the patient's home, I popped my phone down onto the desk, got their consent to use the AI tool, and we had a conversation, a chat, and that just sat in the background doing things. And then at the end of all of that, we summarised our plan, talked about what was going on, and I'd go back, sat in my car, where I can't normally get reception for my computer, for log on for system 1, but I was able to then just quickly edit the output that the AI tool had given me on the phone. So when I went back later into the Jean Bishop Centre later in the afternoon, I literally pasted the notes in. It was all there and done for me. And that process was so much slicker than the sort of scribbling everything down on bits of paper, trying to remember stuff that you'd done before, scribbling all that down on bits of paper, getting back to the Jean Bishop Centre, writing all the care plans, etc., etc. I think that probably saved me, for those 3 patients I saw that morning, probably saved me an hour and a half for the rest of the day.
Excellent, thank you. One question from Jason in the chat around, did you do a time motion study to identify the time savings for staff?
We certainly did a study looking at so we did a pilot looking at the time savings, as in we got staff to estimate before they all got their Heidi login, they also had to fill in a survey for us. So we got them all to do, estimate what their times, how long it took them in each particular work stream to write the notes. And then we redid that survey going sort of back about it's about 3 months into it. We redid that survey again. And it was about 30 to 40% sort of reduction in time there. But we had set it up as kind of brackets of time, which I'm a bit disappointed I did that, because I'd like people to actually specify the number and actually sort of done it that way. So the study we're going to do, we'll be looking at that. Really hard, I think, sometimes to, other than having, I think some of the studies are going very almost through, they actually have someone sat in a room with a stopwatch doing this, which I think obviously is going to be much more precise, but obviously we can't do that sort of thing. But what we are going to do in the next study is record that there are certain clicks that occur on the system when you're doing certain things. So when a note's being created, and then also when you put something into the notes or you click copy, you can put something into the notes. We're going to start recording those times because they approximate very much to the time it's taken to create the note, and use them in this study.
Fantastic, thank you. Mike?
Just touching on that a little, I think there's a temptation to look at the time saving as the key output of this technology, and I think that's an overly reductive of thinking of it. It does save time. I obviously don't have the objective evidence, but though there is plenty of it establishing, I think it does save time is my gut feel. But that's not the main they're not the main advantages. I mentioned a little about the cognitive disbenefit I've experienced, but there is a cognitive benefit as well, in that it frees your brain up from having to try and remember every fine detail of the consultation as you go, ready to write it all up afterwards. You can actually focus on the patient, on the conversation, and that is liberating and relaxing and puts you at ease, which I suspect puts the patient at ease as well, and takes some of the pressure off everybody. And there's other benefits in terms of the note quality, which we've alluded to. There are various other benefits downstream from this that are beyond the time saving. On the subject of the time saving as well, you then got to consider whether there's a natural tendency to think, oh, well, we've saved 5 minutes per consultation. That means we can see X additional patients per day. The patients the practices that I've spoken to that are doing this, and the organizations that are using it, they're generally not seeing additional patients. What they're doing is reducing staff burnout, but that itself has a benefit downstream, because that's less likely to lead to less sick time, less turnover of staff, which reduces training impacts. So I think one of the really hard parts about this is considering the cost benefits. Now, at the moment, the technologies are mostly being offered free to practices and to users, but that won't be the case forever. So I think it's going to be important when we're doing that consideration of cost benefit, the cost analysis, to think of those other costs beyond just it's going to allow more patients to be seen.
Excellent, thank you so much. I'm going to draw us to a close of this section to give people a break, but I just want to say a huge thank you for sharing those presentations, which are absolutely fascinating, and I'm sure there'll be lots of questions and thoughts percolating as a result. So a huge thank you from us. We're going to now take a 10-minute break, give your eyes a rest, take a comfort break, grab a cup of coffee, and we will meet back here at 11:45. So thank you so much.
Introduction. My name is Raghav, but everyone calls me Rags, so feel free. I think typical Aussie thing to have a nickname impressed upon you by the age of 5, so that's the one that stuck. I lead the Heidi Health team in the UK, so based in London, with our team also based in London and Manchester. And yeah, really excited to go through Heidi and product. What I'll do is I've got some slides to share, if that's all right, Laura, just to kind of summarize some of the things that I want to touch on. And then maybe we can just jump into the product and see it for ourselves. Let me know if you have any questions as we're going through this. More than happy to answer them as we go. Cool. Can someone just give me a shout if they can see my screen?
We can see the screen, yeah.
Great. Awesome. Thank you so much. So what I'll do is I will just go full screen so you can see. Cool. So what I'll do is I'll walk you through a few of the things that I think are important to touch on as part of the 30 minutes that I have. Obviously, starting off just with the product, also a bit of our kind of our scale and our use cases and where Heidi's currently been deployed. And then really excited to go through some case studies across a number of different settings. So primary care, secondary care, like outpatient settings, and also community health. Great. So I think just starting from scratch, just in case you weren't here before, but Heidi is an AI medical scribe, or ambient voice technology, or whatever you'd like to call it. And essentially what it does is it transcribes a visit. Then you select what template you want to have the output then structured into some kind of form. So a note, a letter, a kind of progress note, pre-op, whatever it might be. You can select those outputs within Heidi from that template. I'll show you exactly what this means in that kind of that real-time flow. But this is a kind of 1, 2, 3 step process that we like to describe our product with. I think the key thing that if we had to really bring together the product and all the features that we have, I think the key thing that drives everything that we do at Heidi is that no matter where we operate, so whether it's in the UK, whether it's in Australia, New Zealand, Canada, Germany, the one thing that seems to unify all clinicians around the world is that they all like to write slightly differently, or all like to document slightly differently. This is not a trite thing. It's a very, very important thing because of how almost sacred documentation is. Without, I guess, preaching to the choir, I think many people kind of get what I'm my drift is here. You know, that documentation is how information is communicated to the patient. It's how it's communicated to peers. It's a form of memory that the clinician is committing to the medical record. And if you are unable to reflect all the idiosyncrasies that they have built as habits and they deem important, then we've seen it time and time again, clinicians just don't use the product. I mean, I think everyone is really excited by Ambient, and the concept makes a lot of sense. You know, you turn something on and it does a part of your job that you probably don't love to do. But we've seen it, like I said, time and time again, and no matter what deployment it is, if we can't reflect the use case and the style of that clinician, then people don't use it. And if people don't use it, then you don't see the benefits that you're hoping to see. So that's essentially how everything is kind of geared in our product. So that's why you have specialty templates. That's why you have context to upload information into prior to Heidi analyzing it. That's why you have Ask Heidi bar at the bottom. That's why you have a tailored voice section where you can set up how exactly you want the document to be generated. That's why you actually have different ways of transcribing the conversation, which calls a different large language model based on the kind of use case or how you'd like Heidi to generate information. And you can see a bit of like a video there that goes through some of those things. But again, like I said, we'll jump into the product and I can show you this live together. Great, and I think it's worth noting about different use cases and where Heidi can be deployed. So I guess the most obvious one is just on our website. You can sign up and jump on straight away, whatever website you'd like to use. So whether it's Chrome or Microsoft Edge, it works across the board. We also have our desktop app. So our desktop app enables a clinician to transcribe a conversation if they have headphones like I have here. So you don't have to download any audio. You can just use Heidi as a desktop app. It'll transcribe the system audio. So this is great for all of those kind of telephony visits, any kind of Teams meetings, virtual appointments. That's where kind of the desktop app really shines. And then finally, our mobile app. So our mobile app is primarily used for kind of inpatient settings and community health, where Heidi actually transcribes or captures the audio and locally caches it on the device in kind of low or no Wi-Fi zones. So this is incredibly valuable for those community healthcare settings where Wi-Fi is definitely a luxury. And so that's, again, where that kind of, that mode is best utilized. So yeah, whether it's an emergency or same-day emergency care units or district nursing, that's a really strong use case for the mobile app. Great, and then just on our kind of like our traction and some of the stats around the usage of Heidi, I think it's worth touching on this in a couple of ways. One, to just show you the different areas that Heidi's been deployed in, but I think it's also really worth highlighting what this scale gives us as almost a unique vantage point in understanding what is valuable for clinicians, departments, enterprises, and also how to deploy this in the most safe way when kind of clinical reality is always quite unique and variant. So yeah, I'd love to touch on both of those as we go through, but just a high level stats, we have around 240,000 clinicians across the world that have an account on Heidi. And last week alone, we transcribed 1.6 million consultations across the world. When we talk about a lot of the scale, I think it's really important to dovetail this with our clinical safety and our compliance. And obviously, you've gone through some of the guidance as well. What I'd love to do, actually, just after I finish this, I'll send over a website that goes through a lot of this in a lot more detail. And a lot more eloquently than I will do it today. And I'll just send that in the chat so you can have a read over as well. And there'll be ways to reach out to our team if you want any more information. But I think it's really worth noting, just on the point about traction and usage of Heidi. I think our philosophy is very much that build the most clinically safe product that we can, and then use the evidence base that we have generated through Heidi being used out in the world to then constantly iterate and refine the product to make it the most clinically effective and safe product that it can be in different environments. The reason why I say this is because we found, so we've been a company for quite a while, so around 5 years, and we've taken many different approaches to how we can build the best product. And a slightly, I guess, how would I put this? A slightly, almost like revealing way of building a product is having it available for everyone to use, and then having that as the evidence generation for how a product will be deployed. And so that's the reason why I say it's quite revealing, is because there's no hiding what the product can do and what it can't do. It's available for everyone to see. And it's the approach that we found delivers the best results for the clinicians that use our product. So yeah, you've got some of this information here as well on the high level things. But like I said, I'll send you a link that's very targeted towards the guidance and all the things that you would have discussed earlier in this event today. Cool. And then just focusing on the UK, so there's around 60,000 clinicians, around I'd say probably 25% of them or 30% of them use it every week. Last month, we did around 1.6 million consultations just in the UK, and that's across all different settings, so primary care, secondary care, community health, mental health, and around 1 in 2 GPs have a Heidi account. So if you're going to a GP, or if you are a GP, there's a quite high chance that they have an account on Heidi. And obviously quite deployed across different NHS trusts, which I can go through very soon. Cool. Some case studies just to focus in on, I think, just to like really paint the picture and give you some high level stats on the evidence that we're generating today. It's actually worth noting as well, sorry, on the point about some of these case studies and the evidence generation, we are doing some very specific things with different organizations to analyze Heidi's use in live deployments. So you would have heard from Andy Noble just before from City Healthcare Partnership, so from the Jean Bishop Centre, and we're collaborating with the Health Innovation Network of Yorkshire and Humber, so the folks that organised this session, to evaluate Heidi's use. So that's completely independent, but it'll be working with a live deployment, and I think they've been using Heidi in their team for around 8-9 months perhaps. And I think you would have heard from Niels as well from the University of Cambridge. So that's also where we're collaborating with them. So Heidi will be the scribe that they're seeing the usage of in real time with primary care clinics around their area. So yeah, we're really excited to collaborate on these kind of more deep dive evidence generation sessions where they're completely, I guess, independent from the work that we do ourselves. Cool. So this is just a bit of a high level overview of some of the deployments that we have at the moment, just to paint a bit of a picture on some of those stats. There's, I guess, 3 that I want to focus in on. So the first is modality partnership. So modality partnership are the largest GP partnership across the UK. There's around, I think, 53 or more GP practices where Heidi's been rolled out to. A lot of these stats were from the initial evaluation of Heidi, where they had a really kind of stringent protocol on how to deploy it, and we worked with them very closely on this. And some of the stats that they tracked as part of that pilot. So as you can see on the right-hand side, there was a 51% reduction in time spent in consult on documentation and 61% outside of that consultation. And there's a lot of those stats around note quality and confidence in the notes. And just to note, these are all increases. So this is not 38% felt that their notes were of good quality. It was talking about the increase pre and post pilot. You've also got some quotes here from the team. This is actually going to be turned into a bit of an impact assessment that we'll be sharing very soon. So I'll be very excited to share that with the folks on this call. But yeah, that's very, very soon to be released. Similarly with CHCP, so I don't want to go too much into this because I know Andy's probably talked about this a little bit, and I know that a lot of this will come out as part of the collaboration with the Health Innovation Network, but this is a very varied setting within the Jean Bishop Center, some of their stats and some of the evaluation findings. But like I said, this is going to become a lot more robust as Heidi's analyzed as part of their kind of live business as usual processes. And then in an outpatient setting and in same-day emergency care setting, I wanted to highlight West Hertfordshire Teaching Hospitals Trust. So we piloted with them maybe towards the tail end of last year. And I think I wanted to focus on this in a particular angle, which is this research study that Dr. Dimitri has put together. So he's the CMIO of Watford General Hospital. So very large district hospital, and he evaluated Heidi's use in his same-day emergency care team. And so this was actually, he went through this as part of another Health Innovation Network event. I think it was with the East Midlands team. So maybe, I don't know if anyone's attended that, and they've doubled up on this event as well. But yeah, Dimitri went through this. Again, I think this is looking to be published very soon, but just to highlight some of the things, documentation time was cut by 86% for their team. But like I said, I don't want to steal Dimitri's thunder. I know he's already gone through this in a previous event, and we're very keen to have this published. Cool. I think the key thing about a lot of these case studies is that it's not just what the product does, but it's also about how you have all these wraparound services to deliver a delightful experience. And so this is some of the kind of industry average of activation in, I guess, more some of the markets that are more mature in terms of the deployment of this tech. So, for example, the US. So yeah, I know I mentioned a lot about customizing Heidi and making sure that it is really fit for purpose and fit for that clinician. And what we do as a team is make sure that we do a really rigorous kind of implementation process to ensure that the kind of templates and the way that we train clinicians, the SOPs, are all completely bespoke for that organization. One side doesn't fit all in this arena, and even though that might not be the most like hyperscale way to do it, it's what we found to deliver the best outcomes. So it's what we do. Cool. And then just worth touching on some of the quality monitoring stuff. So we have real-time quality insights on our kind of monitoring framework, where it live streams all the kind of key stats that we like to track, and different kind of quality assurance pipelines to real-time assess quality. So we're actually analyzing sessions as they come about. We're able to deep dive into specific sessions once a clinician asks for us to, when we get their consent. So they'll send us the kind of encryption, and we'll be able to access the kind of metadata around that session to see things that went well and things that might not have gone so well. And then similarly, an escalation improvement loop, which is a really kind of well-defined process. So it goes through our medical knowledge team. So there's 3 NHS accredited clinical safety officers as part of the medical knowledge team. It's a team of around 15 to 20 across the UK and Australia. And their sole job, not to make it sound reductive, but their sole job is to make sure Heidi is outputting the things that it needs to or should. And so there's a very, very structured way that we deploy this in real time, and kind of goes through our ethos of how we can make sure that all the information that we get from the 1.6 million sessions that happened last month in the UK, how can we use all of that to make a better product for everyone? And I just want to quickly touch on, I think I'm tracking well for time. So I just wanted to touch on the kind of next act and what we hope for Heidi to achieve as a company. I don't want to go too deep into the details here, but I think the key thing that we believe is, I guess, the future of ambient voice technology is that we believe that there'll be almost like a third space for clinicians to be using a product that's not the EHR. So they'll be communicating with a patient in real time, in the real world, I guess, the physical world. You've got your EHR, which kind of is storing all that information. And then you've also got almost like an AI workbench, which will be able to make your job easier, but also deliver some of the work that you need to do. So at the moment, Heidi sits at the point of care, creating the consultation notes and the documents that I think you're pretty familiar with in terms of what an ambient voice technology platform does. Then what we've just released now actually is turning consults into tasks. So listening into the conversation and pulling out the tasks that the clinician has said that they're going to do with the patient. And then I guess stage 3 is how can you execute on those tasks? So with those tasks, I want to assign some to myself. I want to assign some to people within my team. And eventually, I want to assign some tasks for Heidi to do for me. So can you actually do this for me within the EPR? Or can you actually call the patient for me to book them in the next 2 weeks? Like I said, this is going to be a very, very kind of scaled deployment of the next stack. So I don't want to get too much into the details because this is still something that we're figuring out as a team with the clinicians that use our product. But I think I just want to paint the picture of what this technology can really achieve, and I guess get people excited about some of the things that are on the horizon that we're working on. Great, and yep, this is just a slide about tasks, but I'll show you this in the product. Awesome, so what I'll just do now is I will share my screen. 1 second. And I'll just go into the product. Great, so can everyone see my screen here? Yep, I see a nod from Laura. So yeah, cool, thank you so much. Great, thanks, Nick. Cool, so this is Heidi. What I'll just do is I'll give you a quick run through of some of the core features. So this was a conversation, I think I was working, so this was at the One Heart Clinic in London that use Heidi across their, I think there's 6 practices. And I was showing them a kind of conversation where I was pretending to have chest pain. So yeah, you can see the entire transcript here. What Heidi does actually is live transcribe this. So as the conversation's going in 3 to 5 second chunks, this audio is processed. So there's no actual audio that's stored. It's just this written transcript. And then this is stored on the clinician's account for as long as they want it to be stored for. So we are the data processor, not the controller. You remain the data controller, and you can select within Heidi, so within your preferences, how long that session is stored for. So whether it's 1 day or 7 days or 90 days, and this will be fixed across your team. So I can just show you within a team setting, if you're onboarding a practice or a department, you can tick automatic deletion of sessions and then set it for everyone, and that'll be hard set for everyone within the team. So I think Andy and the CHCP team, I think they have it at around 2 or 3 days. Some have it shorter, some have it a bit longer. It just depends on what fits for your use case as a data controller. There's also a few things here while I'm on this page to note. So different kind of team member role-based access control. So we've got administrators, clinicians, and assistants. So assistants are those who can kind of help with the administration of sessions, but they're not going to be transcribing the sessions on their own. Then you've obviously got clinicians, which is like, I guess, the normal seat on Heidi, and then administrators who can have total access across everything and set some of those team settings that I showed you. And I guess the purpose of this is, while it might not be the most exciting features in the world, it's a really important way to make sure that Heidi is deployed in the way that you feel is right for your organization. So MMFA, requiring patient consent, automatic deletion of sessions, being able to view different team sessions. These are all things that you have complete configurability over. And sorry about the dollars. This is an old account when I was still in Australia. So excuse the wrong currency there. Great, but then what Heidi does is after that transcript, it'll ask you to select a note template. So you've got a lot of different templates here, and this is my example. This is my kind of account, but you can see that we give you out of the box. So we'll give you example kind of SOAP notes or history and presenting complaint, and we'll give one for your specialty. So I've set up my account as a general practitioner. Then you've also got some document templates like patient explainers, ED admission, referral letters, all those kinds of things. So maybe as an example, I'll select the NHS GP consult. Sorry, I'll just reset this. NHS GP consult. So this is actually created by a GP in West Hertfordshire, I think he's based, and he uploaded this to the Heidi community, which I'll show you soon. And it's actually the most used community template in the world. So when we took over my Australian colleagues, I was very happy that day. But as you can see, Heidi's kind of created this note. There's a quick summary at the top. You've got the history section, and it goes through the patient's ideas, concerns, and expectations, past medical history, drug history, family history, social history, examination, impression, and the plan. And this was all pulled from that transcript. Now, what we mean by a template is this. So a template is essentially a way to instruct Heidi to do very specific things. So square brackets telling Heidi what to write, round brackets are telling Heidi how to write, so based on instructions, and everything else is verbatim text. Now this is a heavily guide railed kind of product here. We've actually rolled out a feature. We've just started with our enterprise customers and then rolling it out to the rest, where Heidi, based on the NHS guidelines, will not let you create templates. So before we would kind of ring fence it, but now we're gonna blanket not allow certain templates to be created, just to make sure that we're falling directly within the use cases that the clinician is desiring. But yeah, as you can see, it's a great template created by a GP, and now he shared it with everyone within the community. So I'll just show you here. Yep, you can see it there. It's #1 on the leaderboard, which is exciting. All right, so I'll just go back to Bob Smith. Great, and so this is some of the kind of style things that I was mentioning. So you've got a couple of ways to transcribe the conversation. Extended is perhaps for those more longer, complex sessions where Heidi will take a bit more time to analyze it, but it will be analyzed in a way that is probably more fit for that. You've also got different levels of voice. So this is kind of the style and the way that the information is structured. And then bullet points, quotes, abbreviations, all of these things you can configure on your own. Now for the back of this, I can create many things. Let's say I want to create a clinic letter back to the patient, and I can just see this template as well, just to see how it'll be created. So it'll be in this kind of structure. So I'll just do that here. So clinic letter back to patient. And now, again, based on that conversation, it's going to analyze the information and then structure it in a clinic letter to a patient format. Now, even beyond a template and the voice features that I just showed you, there's many ways to add information or customize it further. So let's say I wanted to dictate into a section. I can select this, and then it'll dictate into a particular box for me. As you can see here, it's just done that for me there. And this is where, if you need to add information, but you obviously don't want to type it out, you can just word for word dictate just into that section there. As you can see, there's a few things here that have popped up. There's find and replace. So I've actually set up DH as drug history. So every time there's DH, it turns it into drug history. So that's why even in the template, even though the template said DH, it has turned that into drug history for me. So I can just highlight that, click find and replace, and then do whatever I want to. Let's say DH is what actually I want now. I've changed my mind. Now I can replace that everywhere forever. And now Heidi will make sure that that is the way that drug history is reflected going forward. I can also create snippets. So let's say you have standard paragraphs that you want to insert into different sections, whether it's a standard risk and benefits paragraph, whether it's a standard kind of section of or like a smart phrase. If you're familiar with products like Dragon Medical One, that's also a way that you can do that by clicking a slash and then inserting the relevant snippet that you want. So as you can see, all of this, hopefully you can see, is geared towards how do we get Heidi to output exactly what that clinician wants, because at the end of the day, that's what we found is the core thing between having a good product and a not so good one. And as I mentioned, this is our task feature, so it's currently in beta and it's just being rolled out across the different groups that we have. What Heidi's done here is it's pulled in the tasks from that session. So as you can see, this one is a coordinate task, and you've got 5 different boxes here. You can see the evidence. So I'll get my PA to reach out and get this sorted. And so now you have a task list for this patient based on these categories. So you can see them all here. In a very similar way, we've built our codes system as well. So I've just turned off SNOMED, but we've got ICD-10 and SNOMED codes. And you can see them in high relevance, medium relevance, and low relevance. And once you've selected them, it'll be appended to the end of the note. So you can also see the evidence as well. Again, very similar way that we've designed this This is not really precisely the same tech. It's something slightly different. I don't want to bore you with the details, but took a lot of time to make sure that this is appropriately exceeding all the benchmarks that we have. And so, yeah, it's something that we're really proud of. Awesome. Yeah, look, there's actually a lot of things, Heidi, that I don't think I'll really get to. So, for example, some of this memory stuff and spelling and how you want to refer to the patient and the clinician, how you want to configure your teams, but I'm conscious of time. The one thing that I wanted to focus in on was integrations, because I think I saw a question in the chat just before about it. So we are going through the IM1 program. So it's an NHS England program to get integrated into both EMIS and System 1. Unfortunately, the queue is quite long. So we've actually been in the queue for probably over a year now, and hoping to get approved for that. So yes, we're working towards the integrations of both GP systems within secondary care. We're integrated into Epic, both through our UK site, so within Cambridge University Hospitals, but also our first integration was with the US site, so that's enabled us to get that up and running. Also integrated with Altera Sunrise, or Allscripts, you might know of them as, and then building out our first proof of concept for our Cerner integration with a site as well. So yeah, essentially integrations. This is for some of them. The timelines are frankly a bit out of our control, but we're doing everything that we can to make sure that we get integrated in the right way through the defined NHS England programs, or processes rather. Cool, but yeah, I'd really recommend anyone to just sign up and see Heidi in action for themselves with some mock consultations or mock patients, and also ensuring that you're doing all the things that are set out in the guidance to deploy it in kind of live settings. A lot of this we also support with, so with our DCB 029, so the clinical safety case report, our DPIA, both within the NHS England kind of structure, but also a separate one. All of these documents is just accessible both on our Trust Center, so you can see trust.heidihealth.com. Yeah, so you can see this actually live here, and you can see all the different certificates that we have. We're actually the only company in the world that has all of these kind of international ones and also the UK specific ones. And then all of these you can request to have access to, and this is basically just sent over. The reason we request is just so we know who's deploying the product in this way, and so we can make sure that we have that touch point. And as you can see, this is the link that I wanted to show you about the NHS England guidance, but this kind of goes into as much detail as you'll probably hope for. Cool. Like I said, I'm conscious of time, and again, probably the best way to do it is just to try it out for yourself. So heidihealth.com, you'll be able to sign up and have a go at it. And please reach out to myself. I'll put my email address in the chat as well if you have any questions. Like I said, we've got a big team here in the UK, so don't worry, we won't be replying to you overnight, even though some of us would be in Australia. We'll get to you in the same time zone. Cool. Thank you so much.
Thanks, Rags. That was really comprehensive. Thank you. There are a few questions in the chat. If you have time to pick some of them up now, in terms of transcription in from different languages, how well the software recognises strong accents or dialogues, and then a note from Glenn around, have you looked at GP Connect as well as IM1? Yeah,
good question, Glenn. I think we scoped out both. I don't want to paraphrase our integrations team, but I think based on the use cases that we were hoping for, we selected the IM1 program to get integrated into. We're actually also going through the it's a omission on my part. We're also going through the partner API program with EMIS. Fortunately, TPP doesn't have a partner API program, so we're just doing that directly with EMIS as well. But I'll get back to you on the GP Connect stuff. Great, so I see MC says, how well does the software recognize strong accents and dialects? It's a really good question. So the way that Heidi actually works is it creates that core transcript, and then what it does is it has a large language model read over the transcript and essentially like make corrections. The reason why we do this is, I think, two reasons. One, because we started in Australia, it's a very, very, very diverse population, and also a lot of funny accents. And so traditional dictation or speech recognition was quite difficult for a lot of kind of hospitals. Like, for example, patient came back from Bali with an illness, would often write it out as like BARLEY. So that's why we have a large language model read over the transcript and then another one to structure the information. So strong accents should be completely fine in. Jason's got a question on different languages. So yes, Heidi can transcribe in different languages. I think we have around 26 that we have benchmarked and tested. Within our terms of use, the language translation feature must be used by someone who can ratify the output, so basically fluent in both. It's not a replacement for a translator. It's just it enables a clinician to transcribe in a language with a patient that they would usually be seeing if they're multilingual. And then Alice, do you know how many vendors are relying on copy and paste? I would say, to be honest, most are relying on copy and paste. There's obviously many that have integrated Heidi into their system, but I would say, yeah, many are using copy and paste. And then I've just seen Alison's at the top about describing GP patient telephone consultations. Yeah, so our desktop app can already do the digital telephony conversations. So yeah, it transcribes the system audio. So if it's just running on your computer, it'll just be able to transcribe that. With the other systems, it's definitely something we can look into as well. I think we've had a chat to a couple, and yeah, could be something on the horizon. So thanks for the idea, Alison.
Excellent, thank you for covering those. Are there any questions from the room? Does anybody want to put a hand up and ask a question while Rags is here? I just had one, if that's okay. Oh, Vanessa, go for it.
Do I have time? Because you know my questions are usually lengthy, Laura, aren't they? Is somebody else rushing in? Have I got a minute?
Have a quick question, and then we'll move on.
It's sort of a lack of understanding, really. So you're saying you can just go onto the website and make an account and use this tool, yet we know that implementation of technologies like this are actually more protected. So what's your implementation journey been like so far with these NHS trusts, and how quickly, when they need to go through the documentation and the checks, how quickly can you implement?
Yeah, it's a really good question, actually, Vanessa. So when someone's jumping onto the product, there's a really, I guess, like structured process they go, both in terms of like the onboarding flow, but also the kind of communication that we send to a clinician based on what we know about them when they sign up. So like what they put in their specialty in their country and everything. In terms of how the deployment has gone with these different NHS organizations, it's, I'd probably say, if I had to categorize it, maybe like 3 stages or 4 stages. The first is obviously all the compliance. So all the documentation, DCB 0160, DPIAs, assessing our cybersecurity posture, all of those things. I guess different organizations usually have different focuses or key things that they really want some information on. And so we have an entire, like I said, we have 3 clinical safety officers and an entire compliance team that kind of goes through that journey with the organization. A lot of this might actually be quite out of the box as well. I know there's a lot of ICBs that we've collaborated with to create DPIAs that can be used as templates for their practices, and same with DPOs. So perhaps that's probably the first way that makes the process a little bit quicker. Then after that, we do a very, very structured rollout process where we call them alpha and beta rollouts. We like to use cool names, I suppose. So alpha and beta rollouts. Alpha is essentially like a really small group of clinicians that represent the larger group that we might roll out to. And that's where we make sure that the templates are all iterated, that we've built really clear SOPs, and that the training is going to be customized for whatever use case, if it needs to be customized. Sometimes it might be that we can leverage something else we've already done, but we like to go through like a really, I guess, structured 2-phase approach for that deployment. So there's the alpha group, and then the beta group is then deploying with each team very specifically. So we deploy with each team, track the metrics and their utilization and all the different hazard logs that they might be implementing, and then make sure that anything is iterated and approved upon as we then scale out. So this process is exactly what we did with Andy Noble and the team at CHCP. We started with a really small group of clinicians, well, not really small group, but a small group of clinicians, built all those templates so that everyone has a great experience from day one, and then deployed in a structured way with each team. I have a few slides that I can send over. I'm conscious of time, but yeah, that's the process that we usually go through.
Can you just say how long that process actually takes in months, weeks, or whatever?
Yeah, it's a really good question. The compliance one's really hard to answer, because I think some trusts taken like maybe 3 months, whereas some have been really quick, like maybe 2 weeks. So the compliance stuff is usually, I guess, out of our hands in terms of how long it might take. The structured rollout process is, the first phase is anywhere between 2 to 4 weeks, and then the rest is just in a by needs basis. So it's usually like a 2-week deployment and another 2-week deployment as we go on, and they overlap as well. So yeah, I guess it depends on the organization size, but we just like to make sure we're doing things quick, but not missing anything as we go through that process.
Okay, thank you.
Thank you. I'm going to draw us to a close. Thank you very much for your time. And if you could put your contact details in the chat, I'm sure there'll be lots of questions to follow up with. Thank you very much. Our next presentation is from Dom from Tortus, who's about to join. Just before he comes on, we'll get to put a link to a mural screen in the chat rather than putting you into breakout groups later. So please do have a look at a couple of questions around support needs and further questions you might have, and please do record on there, and that'll save the kind of slipping out of the breakout rooms later. Thank you. So Dom, can I invite you to take the stage and give us an overview of Tortus?
Yeah, for sure. And thanks so much for the kind invite. So hello, I'm Dr. Dom Pimenta. I'm the CEO and co-founder of Tortus, NHS clinician, still practicing internal medicine, physician and cardiologist. I think what I'll do, I think we have 20 minutes. So I'll briefly run through a bit of slides, talk a bit more about the company and the approach, then we'll do a live demo, and then we can probably just jump into questions. A lot about the regulation stuff I think is quite important as well, so maybe we can cover the recent NHS England guidelines and some of the scale that we've got to. And also there's a question about telephone companies. We actually are integrated into Surgery Connect, so we can talk a bit more about our Axon partnership for our primary care colleagues. If I jump into some slides to start with, share my screen here. And actually share a window might be more sensible. That's a bit better because that should present a bit more nice. Cool. Okay. So as I said, we are I think the only British company in this space. We started out about 2.5 years ago at Great Ormond Street and have since scaled up through the NHS with some of the first hospital rollouts in the country. But to where this story started and what our general mission is, it's a bit broader than just sort of Scribe. So here's an email from myself about 8 years ago, writing to Cerner and saying this is the fundamental problem that we're trying to solve. We started using PowerChart, but compared to traditional paper notes, has several drawbacks. Namely, the practical workflow of a ward round is heavily impeded. And I think the problem that we're really trying to solve is that the computer in the room is slowing us down as clinicians. And here's some really good data to show this is the case. Quantity of mouse clicks in the average electronic medical record system. This is actually Epic, which is pretty well optimized and one that we integrate with. But even so, sending a patient home from the ED, 227 clicks of the mouse. The average doctor is clicking the mouse about 4,000 times in the average shift. And as a consequence, about half of clinicians are burnt out. But we also can't go backwards because the system relies fundamentally now on data, everything from audit to codes to prospective monitoring of quality systems. And actually in the world of AI, the need for data goes up, not down. So the problem that we're trying to solve, and most companies in this space is the interface itself. So Tortus is an AI interface. A little bit beyond Scribe in terms of our ambition, but certainly what I'll be showing you today is our initial product, where we take the speech and turn it into the notes, documentations, clinical codes. And now that we're integrated into a bunch of systems, some downstream tasks as well, like sending messages and collecting data from systems, etc. We use a bunch of AI tools. We've been working in the space for quite some time, and we've also published a lot of evidence about how to do this safely. And that's a real, I think, differentiator for us. We think this technology is super powerful, but potentially also very dangerous. And we're actually very happy to see that. I think NHS England is aligning on that. And we can talk specifically around some of our safety measures, but actually a bit later. I'll skip past this and I'll show you a demo. So I don't know actually if we did this before with the previous presentation, but I like to do a live demo if we can do a quick one in 5 minutes, but I do need a patient volunteer. If anybody would like to give me a fake patient history for 5 minutes, I'll slightly awkwardly leave the floor open for any volunteers.
You can use me if no one else is. Oh, here we go, Jason.
Jason, so very kind of you to volunteer. Hi, Jason. Can you hear me okay?
Yeah, I can hear you fine.
Yeah, very good. Okay, so let me show you Tortus. So, a very simple interface, and there's a very good reason for that. So we are a class 1 medical device. We are on our way to class 2. Every single feature in the app requires a ton of validation, verification, evidence for how it works. So the user set here is very, very simple. We've also studied the cognitive load of using EHR systems, and actually we figured out that the more features there are, often actually it detracts from the experience for the clinician. So we're very limited in that sense, but we think this is the refined data set that most people actually really, really need. So to start a consultation and put the patient's details in here, say Jason. I'll say, hi Jason, welcome back to my clinic. How can I help?
Hi, yeah, I was out playing football with the kids, a bit at Alton Towers, had a few beers, stopped at the pub on the way back, playing football in the beer garden, twisted my knee. I think my kneecap might have popped out. I pushed it down myself and it clicked back in, but since then it's been swollen. I can't sleep. It's very difficult to walk on. So I thought I'd drop in and see you.
Okay, no problem at all. Just tell me a bit more about the mechanism of injury. So if you remember, what were you doing at the time?
Playing football in the beer garden, and I was taking a kick at the ball, but I twisted my leg, trying to bend it like Beckham.
Yeah, I gotcha. And then you said you felt it pop out, presumably that was pretty painful, and you've put it back in. How much can you move the knee now?
Probably about 70 degrees of motion over what I normally can, so I can probably bend about halfway. I can't squat, for example. It's too painful.
Okay, and when was this, sorry?
Last week, on Friday.
Okay, and what have you done for it since? Ice, ibuprofen, anything that's worked?
Paras, ibuprofen, not much really. Just taking those as many as I can per day. But like I say, it wakes me up at night when I'm sleeping. It seems to be more swollen at night.
Yeah, gotcha. Is this, sorry, the right knee or the left knee?
Right knee.
Right knee, gotcha. Any problems with the foot? The foot going blue or cold or pins and needles?
No, everything's fine. It's just that achy pain in my knee.
Have you ever done this before? Any previous knee injuries?
Yeah, I did dislocate it once before back a couple of years ago now. Had to wear a leg brace for a couple of weeks. Had an X-ray, it was fine, but no other injuries since.
Gotcha. And that was the same knee?
Yeah, same kneecap.
Okay. And before that, you've never had dislocations? It's just the 2 times?
No, I mean, it cracks and pops and it sounds like Rice Krispies, but apart from that, it's fine.
Okay. How's your health otherwise? Do you have any other medical conditions?
Asthmatic. I've had a fusion of the L5S1.
Okay.
Back
what
pain.
Was that? Oh, for back pain, sure.
Yeah.
And for the asthma, do you take an inhaler?
I do, yeah. I've got salbutamol that I take as and when required.
Anything else?
That's it. That's it, pretty much.
Any drug allergies?
No, fine with all of those.
Yeah, sure. Anything running in the family at all? Specifically, any joint problems?
Just arthritis, I think. Just standard.
In the elderly, sort of.
Yeah. Upper 70s, you know.
Sure. And how tall are you?
I'm 6'2".
6'2". And how old are you?
I'm 52.
52. Okay. And any other problems in the past or in the family? Any valve problems or any sort of very hyperextensible people in the family or anything like that?
I'm double jointed, if that helps. So it might be to do with that, hypermobility or whatever it's called. But apart from cancer and heart conditions, no, nothing else in the family.
And what cancer and heart conditions run in the family, sorry?
Angina, granddad, father, cancer, granddad, mother.
Okay, we'll see how it goes with that one. And do you smoke at all?
Used to, gave up about 11 years ago when I had my daughter.
Gotcha. And how long have you smoked for before that?
20 years.
20 years. How many would you smoke a day, would you say?
Depends how stressed I was. So probably around about 16 cigarettes. So you can add your plus minus ratio to that. truthfulness.
20 fact years. Okay.
Yeah.
And you mentioned drinking alcohol. How much would you drink over a week, would you say?
I have 2 children, so that's around about half a bottle of gin a week.
Makes about sense in terms of ratio. Sure. Okay, great. I'm just going to examine you. So patient's well at rest. Heart rate is 80.
Ow, that hurts.
Oh, okay. I haven't yet got there yet, but sure. Blood pressure is 140/80. Temperature is 37.2. Respiratory rate is 20. Saturations are 97%. And cardiovascular examination, heart sounds 1 + 2 + 0. Lung base is clear. Abdomen soft, non-tender. An examination of the right knee. Diffusely swollen. Painful on palpation of the patella. Popliteal pulse is present, and so are the downstream pulses, tibial pulses, and good cat refill in the foot. Pain on extension to 70 degrees of flexion, 40 degrees of extension. I don't know, that's a bit too much. 10 degrees of extension, and some crepitation actually on flexion. Okay, well, I think you've done a bit of an injury here. Definitely dislocated it. May have got some ligamentous injury as a consequence. We should do an MRI of the knee. I'm going to give you some stronger painkillers, give you some cocodamol and some ibuprofen, and also a drug called lansoprazole to protect the stomach for a short course to make sure you don't get any stomach problems. I think because you've had recurrent dislocations, we should also get you an X-ray and get you seen by the orthopedics, and I might be able to get you into trauma clinic to get a quick opinion on that later in the week. Does that sound okay?
Can I also ask if that's okay? Because I do already take some medication, so I wasn't sure whether they're going to be sort of, ones I'm allowed to take. So I do take naproxen 200 milligrams twice daily, and also I've got amitriptyline 35 milligrams to take on an evening just for sort of back pain and the like, as well as some dihydrocodone as and when requested and when required. So I wasn't sure whether that's going to have anything to do with it.
Yeah, I mean, you're already taking a lot of those, so let's not give you any new meds. Keep on with those for now, and we'll get you seen by the orthopods. How about that?
Brilliant. Thank you very much.
All right, very good. I like that you tried to break it. Okay, so so first of all, it transcribes, obviously. So the way that the security data flows, I may as well talk to you through. They sit on the system. It's locally encrypted. You get the transcript back, I mean, more or less instantly now, and you can have a look. It's a medical model, but sometimes it'll make a few spelling mistakes here. So amitriptyline, got hydrocodone. And then that passes obviously through to generate the note. Very similar, we've got a bunch of templates in the back, I mean, hundreds and hundreds. You can create your own. We also create them for the organizational level, for the departmental level, and there's some support that we can give around designing that. Once the summary is done, then you can also generate notes and codes and downstream documentation. So we'll just wait for that to return. And there's also a dictation mode here as well. So you don't necessarily have to record the consultation. You can also use it in dictation mode to dictate a note, dictate a letter, and that will actually flow naturally into the note in the same way. Here we go. So this is my cardiology ultimate note. So it's going to be set up for cardiology, but let's have a little look. So patient information, Jason, chief complaint, right knee pain following twisting injury in beer garden last Friday. Kneecap popped out, self-reduced, but remained painful, especially at night. Patient 52-year-old male, so there's a bit more detail there, approximately 70 degrees of flexion, described as sounding like Rice Krispies, and previously had leg brace and X-ray, asthma and salbutamol, L5S1, captured the meds there that you described, taking amitriptyline 35 quite nicely, no drug allergies, angina, cancer, I think that's what you said. Former smoker, 6'2", 52, cardiovascular examination, right, no history of knee location, no paraseasonal weakness. Got the observations there. Didn't talk about that. And then plan for MRI of right knee, X-ray of right knee. So took out that bit that we talked because we had the discussion, not changing the meds, and then discussing with orthopedics. Some codes here at the bottom, so you can sort of choose the codes and it will give you the relevant evidence of where that occurred in the note. We've also got ICD-10, OPCS, SNOMED, the ED coding system, and kind of build any coding system really, and we've deployed a couple of custom ones. So the A&E coding system, for example, is custom for George's. And then if you want to generate a letter, we have a bunch of templates. Let's say GP for referral to specialist would be a common one for this scenario. And again, these can be templated. Now, what you can't do, oh, that's interesting, is ask the LLM to do things. It's very heavily guardrailed because we can't allow users to sort of ask for diagnosis. That's a different class of medical device, describe management plans, or a bunch of other safety features. That's it really on the product side. As I said, and that's a sort of typical colleague letter. And it's also got some notes to the patient there at the bottom. So salbutamol, inhaler, naproxen sort of explanations. You can also create notes specifically to the patient. In terms of integrations, which I'm sure everybody will want to know about, we are integrated into Epic. We're actually doing the first rollouts in the Royal Devon Hospital and Great Ormond Street, so a bit beyond the prototype stage, as well as into Surgery Connect. So for our primary care offering, it's directly integrated to the telephone system, works for inbound potentially and outbound calls, so clinician, but also in the future receptionist calls as well, and gives you the same or very similar functionality. And we're sort of extending that features out now to be able to do more things with database information summarization from the system, as well as doing some downstream tasks specifically for Epic, but potentially with EMIS and some of the other EHRs later in the year. I think I'll probably pause there actually for questions rather than just talking slightly at random, and see what people would like to ask. Let's have a look. So are those bespoke integrations or using like standards like Fire HL7? So Epic is, you sort of have to be integrated to Epic. It's a vendor services agreement. I think it is Fire-based. Smart on Fire is the system, but it's actually a live API. So it writes live into the encounter. It doesn't write to the database. The assurance processes are the same actually for Exxon EMIS, so that's the IM1 system, and we've been quite in the insurance process for that already through our partner. And then Cerner, we use a third party generally, and again can spin that up in a relatively quick time, 4 to 6 weeks. Yeah, system one we should also be live very quickly through Exxon, probably in the next, hopefully next 4 to 6 weeks, depending if IM1 can get us through. And I think Rags mentioned that they are pretty inundated at the moment. Can Tortus guide the conversation to ensure all clinical questions are asked? Super good question. And I think that brings me on to clinical safety. So we are a class 1 medical device. We're on our way to being a class 2B pretty quickly and submitting to a notified body. We're very careful about what the system will suggest to you. And that includes, in fact, prompting. You can use templates to do red flag templating, and we've seen that as part of a way of making sure that clinical questions are answered. We'll also have the capability of displaying the template during the consultation, so you can see as you go down which bits you've missed, which I think in particularly long or complex algorithmic consultations is pretty useful. In the future we will have guidelines, but that's beyond class 2, and we'll be doing that quite soon as we've got those classifications. Can Tortus guide the conversation? Anything to avoid copy pasting? Quite frankly, yes. I do think copy and pasting is potentially one of the biggest risks to the system. Different patient, copy paste into the wrong system. If we had some more time, I could show you the integrations, but they're all closed loops. So Tortus launches from the EHR, it launches from Epic, it will launch from Surgery Connect, for example, and pull the patient details into it. And then when you finish that consultation, it automatically flows back. So it's a closed loop. And I think that will be the standard requirement. And that's also part of NHS England's requirements. How do we access Tortus? Yeah, so for primary care, it's through Exxon. For any other setting, just contact me directly. We've implemented now, I think, in about 10 trusts. We've just finished the largest AVT trial in Europe. Those results will be out in a couple of weeks. 17,000 patients, primary care, secondary care, A&E, mental health, pediatrics. Findings looking pretty solid, 25% time saving basically across the board. New patients and outpatients specifically, 20% increase in productivity in A&E. Ambulance service in London now seeing 200 patients extra a day in the clinical hub. So there's some big productivity gains, but there'll be some evidence coming about that soon. Accents, yes, we did a formal testing, again, requirements for medical device. So we actually synthesized accents and then retested the system based on those synthetic accents. No real degradation in anything except medication names, although this was a model back, so maybe that's better now. but we do say with intended use, you have to use closed loop communication. So repeat the medication names. And we should all be doing that anyway, because often patients and even doctors sometimes can't pronounce the medicines properly. Is there an app version? It's a web app, so you can use it anywhere. You can use it on your mobile, and you can also use it on a desktop. We also allow you to drag and drop recorded files. So one community trust doesn't have any internet. They've actually got their DPA signed to record their consultations as a file, then they drop and process it when they get back to their home base. Actually, sorry, that's the same question. You can record locally without any internet connection. I've done this on a plane, for example. It will just upload whenever there's an internet connection to get it. Currently, all the AI models are only good enough, really, accuracy-wise, to run in the cloud. So they do require an internet connection, but it doesn't need to be continuous. And as I said, you can also save the audio file for later. If you're using it in a system in primary care that's linked to Surgery Connect, they've got the audio file in perpetuality anyway for telephone consultations. So actually, that's an easy one to go back and process whenever you can. Any further questions or anything else that anybody want to ask? I think I'm probably at time, aren't I, Laura?
You're okay with time, actually. You've got probably about 10 minutes. So there's something else.
Oh, I was running for 20 minutes. Oh, sorry. Okay, great. Even better. So what I want to talk about then is the NHS England guidelines. So yes, so Tortus meets all of those criteria. And there's a few specific ones that I think we're quite bullish on. So what I might do, oh, there's one more question. Is this based on an API to an existing AI or is it proprietary? It's actually a mix. One of the things that we have proprietary built is a system for clinical evaluation. In fact, because I've got some time, I can walk you through some of the back-end stuff about how we do the safety. But one of the systems that we built is a proprietary monitoring model. So what we can do with every single note is show the organization the hallucination rate and the emission rate for that specific note. And that's 2 years of research. We just published that initial stage of that study in Nature Digital Medicine a couple of weeks ago. But what I might do as I talk is put that in the chat. And what that allows us to do is to monitor and in real time correct any errors in the system. But B, it allows us to use different models very quickly. So we're constantly updating models. This is the 9th speech-to-text model we've used in 2 years. I think we're using a mix of 2 models at the moment. And again, it's like the 8th version of that in the last 2 years. We're thinking about moving to proprietary models, but currently actually that hasn't been required, but we're fully GDPR compliant, 0 data retention. We don't store any data at all, and therefore we don't actually train our own models because we don't need to. And we don't allow actually any storage in the system either. So it's 24 hours locally. There's nothing stored in the cloud at all. And that means you can't access your consultations or somebody else can't access them from somebody else. It's debatable whether the usability versus security is a requirement, but we think it's a very big cybersecurity risk storing a bunch of transcripts somewhere else. And that's just the philosophy that we've taken. And actually, most of our implementations now are actually fully integrated. So the information saved in the EHR, it's not in Tortus at all. And that's something that we've taken a hard look at. In terms of the NHS England guidelines, yes, I just wanted to talk about that. Nick, I will come to your commercial question in 1 second. Then just open up this document here. That's it. Where are we? Yeah, perfect. Let me share this document. It's always funny to look through my computer. It's such a mess. Great. Okay, so you've seen the NHS England guidelines that came out a couple of weeks ago about ambient voice technology. I think it's super important that A, stressing the compliance, but also some of the why. So there are some basic stuff. Obviously, we meet all of these criteria. Cyber Essentials Plus is a criteria. So just highlighting that one because the Cyber Essentials certification is self-certification, but Cyber Essentials Plus is an external audit. And I think that's why they're stressing that, which we hold. DPA and approval. You can't access Tortus anywhere. You can't sign up yourself. You have to have approval locally. And for any of our implementations, I'm actually really happy to say we don't have anyone using it who's not in an approved organization. And there's lots of reasons for not bypassing those. Clinical safety officers, we have 2. I am actually one of them. And we have a couple in the house as well as an external company. Encryption for sure, and then unsafe functionality. So you'll notice that Tortus doesn't allow you to interact directly with any chatbot. We're about to add a context feature, but it's super heavily guardrailed. You can't ask for diagnosis, you can't ask it for management plans or calculations, because all of that is a much higher level of medical device requirement. We'll probably get there at some point, but we need a lot more evidence and sort of clinical trial capability to demonstrate that. Integrations I talked about, we're kind of integrating to all the major ones and being supported with the assurance processes via Exxon to get into EMIS and System 1, which we're pretty hopeful we should have in a few weeks. And then translation. You can't translate in Tortus. The reason actually is not because the models aren't capable or it's not a capable system. In fact, any large language model today will give you an answer in 200 languages out of the box, and pretty well. And most speech-to-text models will also do that. But all of our system is predicated on clinical safety. So our hallucination detection system, our emission detection system, a lot of the other guardrails in the system, they only work in English. And until we've validated them in other languages, we won't allow you to use the system in any other language, simply because we don't know what the hallucination rate is in Spanish, for example, and what implications that might have on the downstream medical record. Yeah, medical device, I mentioned, we're class 1. We've submitted to a notified body already for class 2. And that's the class 1, as some of you might know, is self-certification, and 2A is when you actually submit to another body to sort of mark your homework, and that's what we are doing at the moment. Compliance-wise, talked about, and system integration talked about. Yeah, and then real-world evidence. So we've run the largest trial. The evidence is pretty good. The time savings are quite effective. We've seen big reductions in cognitive load, as well as clinician and patient experience, and obviously acceptance for many of you who use technology already is pretty high. And that's, yeah. So any questions about guidelines or any other questions? No, I do have a little bit of time left. I can answer those. Commercial model. Yeah, so in primary care, Tortus is actually only available through Surgery Connect. Now, if you don't use Exxon in primary care, it doesn't actually matter. You can still download and use the system. And I think they might be bundling some calls in that as well. So you get a sort of digital voice system, but also Tortus's capability. And then it's quite extended to be able to use it for the reception flow, potentially for some downstream communications directly from the system as well. And Sean said that's interesting. Language is actually a weirdly hard problem now in the world of large language models, and that's the irony, in that validating and evaluating is actually impossible to translate. We have to start from scratch. And that's why it's interesting academically, but painful commercially. In secondary care, we're on G-Cloud 14, so it's a direct reward. All our tenders to date have been actually off that framework. We actually don't charge on the license model. We charge on usage, because secondary care is much harder to track who's sitting in what seat and when they use it. So we have an hours per an hours per organization process model. And that's a minimum contract of £200,000, but there's lots of discounts for yearly use and how many hours you pre-buy up front and things like that. Yeah, happy to have a conversation with anybody that's thinking about bringing it to the org level. Yeah, that's where we are. Any other questions?
Vanessa.
I'm going to ask another implementation question.
Yeah, sure. Vanessa.
So we're speaking to a lot of these, well, a lot, there's not many about actually, of the vendor neutral platforms to sort of host any AI tools. And I know they will also host ambient voice technologies. And I wondered whether you'd had any experience of working with them yet, whether you see them as a positive or negative. The reason we see them as a positive is they become a sort of front door where trusts will be able to plug and play many different AI tools instead of going through that difficulty of implementation every time. So upskill me, tell me whether they're good or bad from your perspective.
I think the general principle, and actually as an AI academic, I'm quite supportive. I think it's a good idea. The problem is they're built for models. They're not built for products. So they're really built for radiology models where you plug an image, you send it for classification, it comes back. It's a very simple workflow. But from what I've shown you, and actually most of these vendors, like these are complex products We won't be able to do that for a number of reasons, but one of them is about the medical device requirements. So we have to control the UI, we have to control how it, how the user approves where the buttons are. So for any other implementations, it's very simple. It's an embedded product. Everything in that box is the same, whether it's in Epic or Exon or EMIS or TPP, because all of our clinical safety requirements are embedded within that. And then the architecture of how it runs will change how the models perform. So if you have a system which, they have X GPU in Leeds, and then they have another GPU in London, the same model will have different outputs if the underlying hardware is different. So there's lots of variables that you then struggle to control. But the biggest bit for us is we've built this clinical evaluation system. It doesn't just observe, it actually intervenes. And that requires us to be able to see at runtime the inference. Putting that into a hospital and then just letting you have at it, we can't then do our post-market surveillance and report back to the MHRA. So it doesn't actually work. But we're quite good at implementation. I think it's just it's a really nice idea. I just think from a product user medical device, all the practical things, it just doesn't really work. You don't just want to observe lots of this stuff. You actually want to do something about it, and then you can't continuously iterate, unfortunately.
Okay, that's really helpful. Thank you.
Thank you so much. That theme of kind of continuous iteration has come out strongly today. So thank you so much. That was fascinating, particularly seeing that real world. I know Jason was playing the patient, but really helpful to see that and how it might work in practice. So a huge thank you. Are you happy to share details in case people want to follow up directly with kind of questions or queries?
100%.
Amazing.
Yeah, thank you. All right, thanks so much.
Great. Thank you. So that leaves us 5 minutes until the start of the next presentation from Accurx Scribe, which will start at 5 We'll just hold off because I think people might dial in specifically for this presentation. So if you do want to quickly stretch your legs or have a comfort break, please be back here at 5 when the next presentation will start. Thank you. And a reminder also just to, if you do have a spare moment, to click on the mural link. We'll put the link again into the chat to give us kind of feedback, thoughts around support needs or areas where you might implement AVT and Scribes. Thank you. Okay, welcome back. So our third demonstration is from Accurx Scribe. So I'm hoping Ben, Vish and Miles are on the call and are able to give a demonstration. Are you there? Yes.
Absolutely. No, we'd love to.
Hi, Laura.
Great, thank you. Thank you.
Brilliant. Lovely to meet you all. I'm Ben, Partnerships Manager at Accurx, and I'll hand over to Vish and Miles in a minute to introduce themselves when we get to the really good bit where they start to demo the product for you. Our aims for this next 30 minutes are threefold, really. We want to introduce you to Accurx and our Ambient Scribe powered by Tandem. We want to show you how Accurx Scribe works, and we want to make you aware of our free pilot offer and how you can access it. So, as I mentioned, Accurx Scribe is powered by a company called Tandem, who we selected after running a thorough market engagement process earlier this year. And I kind of want to kick off with an interesting anecdote that they've provided to us from one of their earliest adopter sites in Sweden, because I'm sure a lot of the discussion today is focused on its the potential for significant time savings with this new kind of AVT technology. But where they're rolling out across this provider, for 95% of clinicians, they were getting significant reported time savings every single day. But there were this stubborn 5%, let's say, that just showed no time savings at all. And when at the end of the pilot, they kind of went into this, these clinicians, and they had a chat with them to understand why that was. So, what was it about, their pathway or their consultations or the way the product worked that wasn't giving them the time savings? They actually found that these clinicians had just been saying they weren't getting time savings because they didn't want to admit that, I'm saving this time and maybe you can give me another 1 or 2 patients. And I think it's just kind of a really interesting starting point for this conversation, because when you reflect, you can kind of completely empathize with that. Year on year, the NHS is perpetually asked to deliver more and more with the same or less resources. This then conditions us to kind of ask how every single possible technological advancement will help us do more with less. And we're forever kind of trying to close that chasm between healthcare demand and constrained supply. And yet no technology really, not even Ambient scribes, which are, you know, fantastic, will stem that volume of patients seeking help, and they're not going to kind of instantly magic up supply that doesn't exist today. But I think what they can offer is something, you know, much more profound. They can create breathing space for you and your colleagues. They can offer clinicians like a precious pause during a otherwise very intense day, or space to truly connect with a patient, to notice things that otherwise might have been missed, and maybe to probe on a medical or even a non-medical issue that might be the real cause of a patient's poor outcomes, you know, today, next week, next month, next year. Or God forbid, actually, they might enable clinicians to go home on time, you know, once in a while. And so at Accurx, you know, our hypothesis is that the real kind of cost savings and productivity benefits will not come from cramming 1 or 2 more patients into everyone's schedules, but from the space that AVTs and Scribe technology can create within your organization to more fundamentally kind of transform the way care is delivered. I'm just going to share some slides, very short slides to help support this, the next part. So here we go. Sorry, I should have. So for those that aren't aware of Accurx, we're a digital healthcare platform, and we're used by 97% of GP practices up and down the country, and hundreds of thousands of kind of secondary care staff every single week to communicate with and about their patients. So I'm just looking for my slide deck now. Here we go. Can you see that? Yes. Yeah. So, so we offer, you know, two-way communication with patients, two-way communication between healthcare professionals, structured and customized patient data collecting, now this new Ambient Scribe technology, and a digital front door, or what we call a digital patient triage route into your service. And we think that using these tools, you can actually kind of create this more fundamental transformation by following some very kind of simple steps. You know, look at what activity is taking place currently and see how we can remove it. So anyone kind of familiar with Accurx in primary care, we've really helped to capture a lot of the inbound and then enable you to remove, like respond to it or deal with it or triage it out back to kind of other providers like community pharmacy without having to provide them an appointment in the first place. In secondary care, stuff like waiting list validation to make sure that these people still require care, or enabling you to collect information that sends patients straight to test rather than having that kind of obligatory first appointment. We want to support you to convert as many appointments as possible to kind of digital, two-way asynchronous interactions. So, you know, this could be sharing like normal test results. Where we work in Leicester, there was a pathway where patients were coming in for their scans every 12 weeks, and then they would be given another appointment for 96% of them to be told everything's fine. You know, why can't that be shared asynchronously? And then we want to support you kind of to streamline the appointments that do need to take place. So those are, you know, can we help you collect information up front so that you can focus more on talking about the diagnosis and the plan with patients? Or can you use the Scribe to allow you to complete your notation and your downward documentation even faster? So that kind of just gives you that little bit of flavor about kind of how we think about Scribe and why we wanted to bring it into our product, but also how else we can work with you to transform healthcare. I'm now going to pass over to Vish and Miles, who talk a bit more specifically about our Ambient Scribe.
Thanks, Ben, and lovely to meet you all today. My name's Vish. I'm part of the clinical team at Accurx, so clinician by background, but we're working with Accurx now to help make sure that the product that we deliver for our users maintains its clinical integrity. I'll just hand over to Miles quickly to just quickly introduce himself, and then we won't keep you too long away from the magic. So yeah, I'll hand over to Miles.
Oh, thanks, Vish. Lovely to meet everybody. So my name's Miles. I'm also a clinician by background. Like everyone else in the UK team at Tandem, we're all current or ex-doctors and really understand the pain points in healthcare. So I left as an EDSHO, fed up with the state of admin and note-taking, and I'm really passionate and excited to bring Scribe into the hands of all of you guys and share a little bit of the magic we've built today.
Great, thanks, Miles. And before we go into that demo, there's just a few things that I think is, always very relevant to talk about with a bit of housekeeping when it comes to Ambient Scribe, just to make everyone aware of a few key things. So as you can see on the screen there, it's Accurx Scribe powered by Tandem. Tandem is our trusted partner who we've chosen to bring this technology to the NHS. And when choosing that partner, we evaluated, a range of leading providers. Tandem really stood out. 60% of their team across Europe, as Miles said, are clinicians, set a really high bar for clinical safety, privacy, and NHS compliance. They're ISO 27001 certified, GDPR compliant, so really, really trustworthy in doing that. And off the back of that, we at Accurx, we really welcome NHS England's guidance on ambient voice technology. And what we're really happy to say is Accurx Scribe powered by Tandem, already meets or exceeds all of those core requirements. We've got Class 1 medical device. We're pushing for Class 2A medical device with future functionality coming into play. We're DTAC ready, Cyber Essentials Plus certified, regular CREST approved penetration testing. We've got named clinical safety officers, so we're DCP 0129 compliant. We've also built resources that help organizations satisfy their DCP 0160 compliance as well. So really there to support teams on making sure that compliance assurance is in place. In a few other things, Accurx Scribe as well, what I really like about the way we've built our product is that we're already integrated with key clinical systems. That includes EMIS, System 1, Rio, CETO, PDS, Vision via NHS approved APIs. As an IM1 supplier, we support HL7 and FHIR standards, and really looking to support that full interoperability across all NHS healthcare organizations. We've also got NHS Mail single sign-on, so this is also fully supported within the platform as well. The other thing I wanted to, just talk about was implementation. Accurx as a company, we're 220 plus strong team that's deeply familiar with NHS workflows. We offer boots on the ground support for any new product, particularly Scribe that we're implementing on the ground. We've already rolled out Scribe to over 1,000 GP practices and NHS organizations, providing hands-on implementation along the way, training and transformation support. And the last thing I'm going to just talk about is this general concept of intelligent workflows. Obviously, ambient voice technology, when you look at a lot of what we're providing, lots of other suppliers are providing, there's a lot of similarities in terms of what's actually produced and the product itself. But what we do know is that Scribe itself can't exist in a silo. Creating a note or creating some documentation is just the first step of actually transforming someone's care journey. What matters is what you can actually do with that output. So why we're really excited about bringing a Scribe into Accurx is that it can actually deliver outputs in real time, generate a clinical letter, save that back to the record, message it directly to the patient using Accurx, or maybe message it directly to a GP or other healthcare professional at the same time, all within the same platform. There's also a mobile version of the platform that allows you to use Scribe on the go. So that's really useful, particularly in community settings or home visits or whatever it might be. So Scribe outputs really need to be integrated into that communication fabric of care so that you're not switching systems, you're not chasing admin, everything is joined up and delivered faster. So with that in mind, that's just a bit of an introduction. I'm just going to hand over to Miles, who's going to kickstart the actual demonstration. I'll hand over to you, Miles.
Brilliant. Thanks, Vish. Okay, I'm going to start with sharing my screen here. Okie doke. Brilliant. So can everyone see this?
Yes, we can see your screen.
Great. And are we including this green toolbar up here? Brilliant. Okay, great. So thanks so much for your time, everyone. Really excited to show you this. Just in terms of a quick rundown of what we're going to see in the demo. I know that we've got a mixed audience between some primary care and secondary care focused colleagues and a mixture of clinical and non-clinical. So what I'd like to do is basically just show you the workflow if I was a GP and I had a patient come in. And we'll do a pretty high acuity scenario where Vish gets to flex his acting skills a little bit and illustrate not only the kind of notes that we can generate, but also some of the downstream documentation that we can generate that's really important and can assist with things like high acuity handovers and ongoing patient care. Talk a little bit how that ties back into the communication platform. But we'll start off, and this should be a familiar sight to some of you. So I'm going to demo this in EMIS, where we have our full integration, but we have almost the exact same process in System 1. So when you sit down in your surgery and you're ready to go, you'll log into EMIS, you'll log into Accurx like many of you will probably already do, and that's it. There's no added steps to be able to use Scribe, so it's really user-friendly. You just need to open a patient within the patient record, and we've got a really deep, robust integration. And what that means is you don't need to be on this consultation screen for the saving to record to work. You could be looking at bloods, recent consultations, medications. As long as that patient is open in the background, you'll be able to save your consultation. When you're ready to launch Scribe, all you need to do is click on the microphone button up here, and you will be automatically signed on through your existing Accurx login. I'm just going to full screen the window here to make it easier for everyone to see. So first thing to accentuate, obviously, we've got a really user-friendly interface here. So Scribe is already launched. There's a big blue button encouraging you to get started and greeting you by name. So if I go ahead and get started, I'm going to go ahead and start the encounter. First thing to realize here is that you can see I've already started the encounter, but I'm still explaining how the product works to you. So we have a really sophisticated content filtration system with Scribe. Only the relevant bits of information will get pulled through into that eventual medical note, but we've also worked really hard to make sure that other things aren't excluded, like, for example, important bits of social history, etc. But you shouldn't have to pause and unpause continuously because the emphasis is to get you a really continuous, easy workflow that minimizes interventions so that you can focus on the patient. On the left side here, you can see all of your consultations from the last 30 days. So this syncs like immediately with our new mobile platform. So say, for example, you're out doing a few house visits and you scribe each one as soon as you get back to your surgery. Or indeed, if you're doing like house visiting in a secondary care setting and you get back to your laptop, all those consultations will be here ready for you to edit and then seamlessly save to record to help you remember all of those visits. It's worth saying at this point, I know you've seen several demos already, so I'm keen to also give you some tips and tricks from our experience with Scribe. Down here, there's an add additional text button. Now, if you've had a patient that's had a recent consultation or someone that you see very frequently with a complex history, or if you already use Accurx and you've sent out a survey or something like that, you can paste all of that information into this box, or you can dictate directly into it and then save it, and that context will go into the eventual note to kind of enrich like the quality of the final output. So generally, the more Scribe understands about what you're trying to achieve and what you're seeing the patient for, the better quality note you'll get. Similarly, this is a great time to just tell Scribe a bit about what's going on, what you're seeing the patient for. If you're in clinic and you've got some notes you're reading through, explain the recent investigations and bloods, etc. And that'll really help to increase the quality of the output and make sure that everything you want captured is captured. But without further ado, I think we'll jump into it. If Vish is ready, are you ready, Vish?
Yeah, all good.
Awesome. All right, so let's get started. So I'll say hi there. Good morning. My name's Dr. Miles. Thanks so much for coming into the surgery. Before we get started, I just want to let you know I'm using an Ambient Scribe today. It's going to listen to our conversation and then produce a medical note for me so that I can focus on you. Is that okay?
Yeah, that's fine. Absolutely.
Oh, brilliant. Thanks so much. Before we get started, can I confirm your name and your date of birth, please?
Yeah, so my name's Rowan Bean. Date of birth is 22nd of February 1973.
Okay, great. Thanks so much. Rowan, I'm just having a look at your triage form here. It looks like you've come in with chest pain. What's been going on?
Yeah, it's this tight pain in the middle of my chest. It started this morning while I was just watching some TV, and it lasted about 10 minutes. Then it started again about an hour ago, and it hasn't really stopped since.
Okay, gosh, I'm sorry to hear that. What does it feel like exactly?
It feels a bit like a heavy pressure. It's not really gone away. It's going down to my arm on the left side, my jaw. Yeah, it doesn't feel great.
Okay, I can understand that would be worrying. I mean, how bad's the pain on a scale of like 1 to 10, would you say?
Feels pretty bad, doctor. It's probably about a 7 out of 10. Took some paracetamol, but it didn't really touch it.
Okay, I'm sorry. Have you been feeling like breathless or sweaty or feeling sick? Any other symptoms with it?
Probably all three. I've been sweating loads, yeah.
Oh, okay. Have you felt dizzy or lightheaded or lost consciousness, anything like that?
No, nothing like that.
Okay. Is this the first time you ever had anything like this?
Yeah, I've never had something like this before.
Okay. Do you have any other medical problems? Are you on any regular medications or anything like that?
I've got high blood pressure, doctor, but I take a tablet called Ramipril for that.
Ramipril.
Yeah.
Okay. Yeah. And are you a smoker or a drinker?
I smoke about 10 a day. Have done for about 20 years or so. But yeah, I drink now and then, but not very often.
Okay. Any family history of heart problems, early heart attacks, anything like that?
Yeah, I thought you might ask. My dad had a heart attack in his 60s.
Your dad had a heart attack in his 60s. Okay. Listen, I'm a little bit concerned by this history, to be honest with you, Rowan. I think I'd just like to examine you quickly. I'm going to speak my findings aloud just so Scribe can pick it up. And while we're going, I'll just get an ECG done as well, so you'll have some sticky pads on your chest, okay?
Sure.
So we'll start off with some observations. We'll say you've got a pulse of 98, a blood pressure of 142/88, SATs of 96%. You got normal cardiovascular examination with normal heart sounds. Your chest sounds clear from a respiratory perspective. We'll say we do an ECG here quickly, and we'll say I'll have a quick look at it. So Rowan, this ECG shows changes that suggest to me that your heart might not be getting enough oxygen. This looks to me, I don't want to worry you, but it looks to me like you might be having a heart attack.
Okay, I was worried that might be what's going on. Does it look really serious?
It may be. I think I need to call an ambulance and we need to get you straight to hospital. While you wait, I'm going to give you some aspirin and something under your tongue called GTN for the pain, and we'll monitor really closely here for you. I'm gonna call an ambulance and tell them that your ECG shows ST elevation in leads V2 to V5, and you've got cardiac sounding ongoing chest pain. I'm going to make sure to alert ED and the cath lab at the receiving hospital so we can get everything ready for you. Rowan, listen, it's really good that we were able to fit you in quickly and that you've come in. I want you to try and stay calm and stay still. We're going to look after you until the ambulance comes here. I want you to make sure if you start to feel dizzy or lightheaded, your shortness of breath gets worse, or if you start to feel any palpitations, I want you to let me know, okay?
Yeah, I will do, Doctor. Thank you.
Brilliant. Thanks so much. Okay, so that's the initial bit of the consultation done. It's worth saying at this point that we can pause, unpause the encounter later, and that can be a really powerful tool. So it's not as relevant in this consultation, but say you've got a more psychosocial consultation, or there's some sort of sensitive findings, maybe safeguarding problems that you want to let Scribe know about, but not necessarily right in front of the patient. You can pause this and pick up this encounter later on after the patient's left the room. But once you're happy that you've said everything you want to say, we can click Finish and Create Note here. And this is going to populate one of our GP templates, which is built to integrate really well with EMIS and System 1. But we've got a variety of templates already built out across a load of specialties in secondary care, anywhere from outpatient clinics to allied health professional clinics, nurse-led clinics and GP, physiotherapists, mental health. So we've got a really wide offering. I'll just walk you through the note quickly so we can see how quality the output is. So we've got this chest pain that started this morning, lasting 10 minutes initially, and then recurring an hour before the consultation and being persistent since. Heavy pressure radiating to the left arm and jaw, 7 out of 10. Paracetamol didn't help, associated with sweating, breathlessness, and nausea. But you can see we've picked up the important negative symptoms here as well. So denies dizziness, lightheaded, loss of consciousness. And this is the first time the patient's had this before. We've got the history of high blood pressure, for which they're on Ramipril. We didn't give a dose. On the examination bit, one thing to show you here is that we've got these underlined phrases. So this is what populates essentially when you say that you've done a normal examination, and this is user customizable. So we can actually edit this and change it. So if you've got a certain way of saying like an examination is normal that you're used to putting in notes, like maybe you like just saying no added heart sounds, for example, you can change that and it'll remember it every time. That's how you like writing that. And then we've got our heart rate and SATs. We've got our blood pressure pulled through separately here because this is one of the things that we support, literally coding directly into the record with SNOMED coding, which we can do with our integration, the family history of a paternal heart attack, the smoking history, the comment, and then the plans. We've done our ECG with ST elevation, administered aspirin and GTN, etc. So what I want to show you before we get into anything else is the quick and powerful ways that you can edit the note. So the first one, obviously, is you can type directly into the box. So I could say, otherwise well recently, for example. You can also dictate directly into the box, which is a really powerful dictation powered by a well-trained medical automatic speech recognition model with a big dictionary of medical terms to pick up all those tricky acronyms and monoclonals that nobody knows how to pronounce. And then also we've got this add or adjust button down here where you can make sweeping changes to the note really quickly. So this is how I normally edit my notes. But you could say, for example, actually, can you add in that the patient has a history of type 2 diabetes for which they're on metformin? And can we add an allergy to penicillin? So you just pop that bit in here. When we're happy with it, we click the blue arrow, and then everything that changes will update in blue, so it's really clear. So you can say we've now got our type 2 diabetic history with metformin, and we've got a pen allergy down here. You can also make changes to structure with this if you want, say, the history in bullet points with something more acute, etc. So we're happy with the note here, but our project doesn't end with generating a note. So the next thing to talk about is some of the downstream documentation that we can produce using Scribe. So this is a high acuity situation. So maybe I want to send the patient along with a letter that they can take to A&E so it's really clear what's happened. And the ambulance is getting it quickly, so I don't have time to type it. So I can generate an urgent letter, which will go through the patient actions with some of the safety netting advice I gave them, what I'm worried about, an acute MI, based on ECG findings and clinical presentation, the ECG we performed, a bit about the patient, and then the summary. So I saw this man today, what's happened, examination, etc. Also, maybe I'm calling up A&E and I want to alert them to the patient that I'm sending in. I could generate an SBAR handover report here, so it's really clear what I need to say and send them in with this. This is also really poignant in secondary care. We've done some paramedic service demos, for example, for this, where we're generating ambulance handovers. But you can see we've got a similar really structured output here with the assessment that we did and some of the ongoing recommendations. And we can also generate text messages, etc., for the patient with what happened. Before we get into the Accurx onward comms bit, I just want to show you the party piece of this, which is really our integration. So I finished my note here, and I don't have time to sort out all the formatting from copying and pasting it. I click Save to Record here. It's going to pop up and confirm the correct patient, which this is, Rowan Bean. I'm going to click Save to Record, and I'll pop back into EMIS. And just like if a colleague had edited the notes while you were looking at it, we'll get a little alert up here that the record's been updated, and then boom, in the EPR correctly in history section, examination section, we've got SNOMED coded blood pressure report in there correctly, comment plan, and everything is in its correct place. It's not just dumped, copy and pasted in a text box. And we're looking to start introducing searchable problem codes in the next few months as well to let you problem code from Scribe. Before we finish off, I just want to bring us back to the text message, and I'm going to hand over to Vish a little bit to talk about how these documents tie in with the wider Accurx piece.
Thanks, Miles, and I'll make sure we get onto questions very soon, because I'm sure there might be some coming through, particularly when it comes to embedding Scribe within the Accurx platform. As I said earlier, we don't want it to be this silo tool that you just create a Scribe, you don't really know what to do with it. So Miles has shown you how you can get that into the record, but you can also do onward communication with it. So say, for example, this particular message, you wanted to ping a message off to Rowan as he leaves the GP practice. You can just click Message Patient from the Accurx toolbar. It populates straight away from the patient records. You can send that message directly to them. So that's really, really helpful. The other thing you can also do, say, for example, you created an urgent letter and you want to send that to your local GP, the local A&E, you can literally just click on the app button there, which is our AccuMail feature that allows you to send onward communications to other healthcare professionals in the NHS. So you can literally populate that message to send them directly rather than having to print off a letter and ping that over to them as well. So that's what really we're trying to build with putting Scribe into the tool is, yes, Scribe is great, it's amazing, it's going to create a huge amount of benefit, but how can we unlock really, really quick actions off the back of that that are seamless and within the same platform? So I hope that's clear. Thank you so much for allowing us to demonstrate. Yeah, happy to hand back to Ben. I think you're on mute, Ben. You might still be on mute.
That's that traditional problem of having too many windows open there. So thanks both. I was just going to share one final thing before we open the floor to any discussion is that we are currently offering free pilots of Accurx Scribe to secondary care organisations. For those of you that work in primary care, you'll know that we have also extended this to primary care. And so, yeah, if you'd like to try it out in your organisation, we're starting kind of from a standard position of 3 months free trial, but as part of that, you'll get boots on the ground implementation support to roll out. You'll have complete transparency on future costings, and if you want access to the wider suite of Accurx functionality, you can have it. And I'll just pop a little link in the chat for you to register your interest if you so wish to discuss that with us. But you can also reach out over email, and I'll put that in there as well. Thanks. So, any questions?
There's a couple in the chat. Oh, sorry, Vish, you're on mute. Do you want to?
That's me doing it now. Yeah, I think there's a couple in the chat. Ben, I'll just check if there's any on the Q&A that we need to pick up. First one was, and this might be one for you, Miles. can it be set up with more complex templates, or does it just work with the basic EMIS and System 1 GP consultations?
So I think the first thing I'll answer both versions of the way I could interpret this. I think the first thing you may be asking is within EMIS and System 1, if they've got custom templates, if we can work with those. So at the moment, we're still building out our template offering, and the approach that we're taking is mirroring the existing EMIS System 1 templates you might have. So for example, we've got a few like asthma nurse clinics that are running GP that we've built templates for, and integration for that at the moment is copying the box and then putting into that. Or alternatively, you can use our existing integration if you're happy to just have it go in that structure. But it won't kind of, if you want to go into the existing EMIS template, so you've got it used for downstream stuff, it's being copied the specific fields into that template. If you mean more, do we have like more complex templates in other areas, like for other health professionals or specialty stuff? Yes, we do. We've got a large variety and we can build really specific templates.
Thanks, Miles. And this may be one for you, Ben. We're an Accurx GP practice users. I put my name down, however, not heard anything yet. What are the timescales? I'm sure there'll be a lot on the list.
Yeah, so I believe that the rollout has started this week, so you should be receive some kind of communication this week from them. But I'll note down your practice, and I'll just go and explore that with the team and get back to you. And then I see Nick Hamilton has asked about the current extent of adoption, use of Accurx Scribe in the NHS. So in terms of Accurx Scribe, it's been rolling out over the recent weeks to about 1,200 practices so far, I think, so GP practices. And we are also now rolling out across secondary care. So we've got a couple of official three official pilot sites, which for procurement reasons, some of them I can't mention at the moment, but two large teaching acute hospitals, one in the Midlands and one in the Southeast, and then also a community and mental health trust as well.
Yeah, and I think an interesting point on the adoption piece, in one of those trusts that we were piloting in, obviously, as you can imagine, with lots of pilots at the moment, multiple providers coming in and piloting at various different sites, which is absolutely the way to do it, to settle on your best option. I think we were really happy that because of that implementation and transformation support we were able to offer, we were able to roll it out in a couple of weeks and get the most widespread usage across the trust of that particular platform. And I think that, yeah, that speaks to how important implementation actually is. You can obviously build the tech, but you need to really support people in using it properly and and safely and sensibly. So yeah, really happy to share that as well. Laura, I think you've got your hand up.
Thanks. Yeah, just a quick question. You mentioned the content filtration system and the system taking out, I guess, bits of conversation that aren't relevant. Could you talk a bit more about how it does that and how you're assured the right things get into the consultation? And then just picking up on your implementation point, could you just talk about what does boots on the ground look like? What would people receive in a practice or a trust? What would they get?
Yeah, I'm happy to do both, or I'll do the first one and we can share the second part.
Yeah.
So in terms of content filtration, basically what we do is, first of all, in terms of I guess there's two pieces. There's the transcription generation, so taking the raw speech input and turning it into like medicalized language. And then there's the second part, which is how we take the raw transcript and bring it into the notes. So we basically engineer on our side each section, telling it what sort of things should be included, what kind of things can be included, and trying to narrow down the scope to keep it relevant, but also allow details to be brought through that you would want brought through. So we control that on our side and do regular sort of like iterative testing, note reviews, etc., to make sure that there aren't any omissions and also that there's not like excess information being included. And we've improved that over the last couple of years now steadily. I think the main thing to say for the other part of that, where you say, if there isn't something being pulled through, or you want something else mentioned that wasn't mentioned, one of the things that I didn't actually show in that demo, but that we can do and is worth knowing, is that the notes and documents that are produced, once they're there, it's not like that's the end result. So that Smart Adjust button that I showed, the Add or Adjust one, that has access to the transcript, and you can give it instructions like, you know what, actually, can you talk a bit more about this? Because they talked about this and I didn't really feel that came through in the consultation. And it can restructure the note, you know, make things more evident for you. So say for example, they came in and they talked a lot about their dog that had just recently died, and actually it was really distressing to them and maybe didn't pull through into the medical parts of the consultation, and you want to say, you know, this was quite important to them, can you pull it through into the social history? We can do that just by you asking for it. So there will inevitably be some times where you feel you would have mentioned this or you would have not mentioned this, and we work really hard to make sure it's as good from the get-go as we can at getting that match for you, but we've also worked to make it really easy for you to make those adjustments yourself.
Yeah, I think the thing I'll follow on from that as well, Miles, is the easiest way I sometimes describe it is if someone comes in and talks about the weather or the parking or whatnot. Like, it's really good at just, you know, filtering out that sort of stuff. So yeah, it's just like I guess a bit of a delighter for users in that case. In the second question, Laura, was around what does boots on the ground implementation actually look like, which is a really good question. So as I mentioned earlier, you know, we've got 220 person company. We've got a very formalized, structured customer success and implementation team that's basically situated across ICB and regions. So if you look, say, for Yorkshire and Humber, there'll be a customer success manager, there'll be an implementation manager who work directly with practices and organizations in that region to ensure that we're delivering Scribe as valuably as possible. That includes, yes, practice visits to come down and sit and talk through your challenges, webinars, one-to-one onboarding calls, you know, tips and tricks, etc. You know, we've got was it 5 days a week or 6 days a week, Ben? I can't remember. We got, you know, our support team that if you get in touch with them, they'll respond back to you within 5 minutes.
It's 7 days a week now.
7 days a week. 7 days a week now. That's even I didn't know that. That's great. 7 days a week, you've got our support team where you can get in touch if you've got any problems, and they'll always get flagged to the right representative within the company to manage that region. When we talk about, say, bigger organizational deployments, you know, say community trusts or secondary care organizations, that is literally, we will come and sit with you a day a week, a day every couple of weeks to walk through people through the platform, get it set up in the right areas. One of two reasons. One is we want to make sure you're successful, but secondly, it's a core principle at Accurx that all 220 people have to go on 1 or 2 practice or trust visits every 6 weeks, every 6 to 8 weeks. It's like a core part of how we're building it. That's the only way we're going to know how it's going to get better. So we almost see it as a good opportunity for us to come in and learn from you and see what else we need to be doing to improve our offering. So yeah, I hope that answers your question a bit, Laura.
There's and in the resources we provide, we've linked in the there's a bit more information about some of this as well. So, you know, you'll have a transformation lead, you'll have a partnerships lead, you'll have a clinical lead that you work with, and then you'll have access to our data and behavioral science expertise as well within the company. So, yeah, and a technical / product lead. So all of these people, you know, you will see it at regular intervals, both virtually and face to face.
Fantastic. Thank you so much. Thanks to Ben, Miles and Vish. We really appreciate your time in the demonstration. Thank you very much, and hopefully everyone has seen the links, but we'll circulate them when we do kind of round up after the event. So thank you.
Perfect. Thank you all.
That brings us to our last but not least demonstration of the afternoon. So I'm hoping, I think I saw her on the screen, Amanda from RDI Inicio. Amanda, can I hand to you?
Yeah, of course. Thanks, Laura. I've got a couple of the team with us as well, in Aimee and Mike, hopefully here too. Mike is going to share the slides for us as well, if that's okay. Or not.
That's okay. I can share the slides.
Oh, Aimee, thank you.
Let me know. Can you see that?
Yeah, perfect. Thanks, Aimee. Laura, thank you. Thanks for inviting us along. I'll just start by introducing myself briefly, very quickly. Amanda Sparks, Chief Clinical Officer with RDI Inicio, formerly NHS lifer, some 27 years in the NHS, with a lot of that spent in around the surgical domain. Finishing up. Oh, we're running through the slides there, Aimee. I don't think even I could keep up with that.
Sorry, I'll sort that out.
That's
again.
all right. Thank you.
You carry on.
And essentially, I mentioned the history as being important because it's where the seed for Flight Deck, which is a product we're going to speak about with you, was founded really, and that was in our journey. My last role there was at the Royal Free London as Director of Operations and Nursing, and whilst there, we have the absolute privilege and unique once in career time journey of digitising a brand new hospital and taking it through on its HIMSS 7 journey, so that real high digital maturity. But in doing that journey and achieving that HIMSS level 7, something we learned very critically important was, one, how to bring your people along on a journey of transformation like that, but the importance of system learning, and how important that became in terms of moving from kind of this rear view mirror way of learning from incidents through to very much a proactive learning, and how data can enable that, and data-driven decisions can enable that faster. And that will fall into place as I go through and talk about Flight Deck and what it is. I'm going to wrap some context around, because I understand you've been hearing from others today. We are very much at an earlier stage in our life cycle as a product, but hopefully we'll keep the excitement going in terms of where we're at and what it's pointed at doing, and some of the problems that it's set to answer. Aimee, are we good to go?
I'm just trying to.
We've had some issues all day between us, so apologies for this. Let me see if I can share again now. Bear with. There, let me know if you are able to see my screen now.
It's coming. You just see your initials at the moment. But yes, now we can see your screen.
And hopefully in presentation mode as well. Everything. So I think the heat's got to everything now. I've got a thumbs up from Nick. Can everyone else see that presentation? I can't see you guys now, so.
Yes, we can see the slide. It's not present. Oh, it's about to come into presentation mode. Yeah, it's there now.
Right, we're there. Okay, it's a wee bit slow. So I just wanted to start with that problem, the problem that we set out to solve, and not sure why it's doing that. So annoying. Apologies if I'm preaching to the converted as well here, but just a few of those stats in terms of the problem that we're solving. So really understanding. Oh, that's really not good, is it? Is that changing for you guys as well?
Yes, it is. It's flipping around a bit, but no, it seems to have settled now. So.
Hasn't it? So some of the problems we're looking at solving is really about avoiding that harm around unsafe care, the avoidable deaths each year, the costs associated with that as well. We have seen a little tipping down of never events as we've rocked through the last couple of years, but they're still far too high, with more than one a day across England at the moment, and a cost of 800 million to the NHS each year in terms of compensation. The problem we feel is, or certainly I do from my lived experience as well, that's more on the underreported, unseen side, is the impact that's having. Thank you, Aimee. The impact that's having on our staff and the wider ecosystem that sits around the patient. So the patient harm is an obvious one. But the second victim syndrome, so that impacts our workforce and the extended family, friends circle that sit around the patient as well. There's an awful lot of research, thankfully, now coming into the fore that really look at the impact it's having on our workforce, with nearly 80% reporting difficulties concentrating when they've been involved in either a serious incident or a never event. And actually, some of these symptoms vary from anything from more stressed at work and carrying that stress into work, right the way through to leaving the profession, leaving the trade, and sometimes even worse outcomes for our workforce, with examples of, unfortunately, self-harm and sometimes suicide across the professions of our MDT as a result of being involved in and potentially poorly supported after such events. There's also an awful lot of evidence that's banking up now around the fact that these risks could really be decreased significantly if staff perceived that their organisations were supporting them through the response to such an incident. an experience, again, from coming into nursing nearly 30 years ago, right up to present day. The way we're learning from never events and serious incidents really hasn't shifted. So it's still very much in that retrospective space. An incident occurs, a very long report, too long to read, is written. That takes 6 to 9 months to come out with an action plan that sits behind it that's really quite one-dimensional, very static, and actually misses the salient points around the behaviours and the human factors that were involved or predicated in, at times, those errors and incidences. Aimee, if you don't mind moving on, if that's okay. There's a publication recently actually that just came out of the States where we also have a presence. The statistics are just absolutely harrowing for me as a clinician. I think anyone as a human really, but 70% of the never events that are reported over in the States have a fatal outcome. That's an unbelievable piece of reading there, but essentially it's what our vision is to have that zero never event health system. They were named never events for a reason, I believe, and I really think we should be doing more in that learning space to surface the human factors impact and to be able to shift the dial in terms of how we learn and prevent going forward, as opposed to learn in that rearview mirror. If you don't mind changing again, Aimee, thank you. We've done a lot of learning in healthcare from aviation. A lot, we think of SBAR, there's other tools that we are widely recognised within across healthcare now that have come from aviation. And I think the important thing to surface from some of those learnings is actually being able to capture the information in the first instance. And something aviation did very well once they introduced the flight deck recorder was be able to create surface all of that conversation and decision making that's going on and being able to learn from that going forward. I had an interesting conversation with a CCIO recently who's part of one of our pilot areas for flight deck, and we can learn from aviation, but the key difference and this was his view, it was quite well caught, I thought, is actually when you're on an aircraft, immediately the whole team is invested in the safety of that aircraft, because if something goes wrong, everybody is impacted. And the feeling, the culture in our operating theatres and other spaces across healthcare is that it won't happen to me. I go home, there's no impact consequence outcome for me. And I want to really surface that yes, there is, and actually incidents in the operating theatre can be carried far wider than the team that are stood in the room at the time. But a well caught point there by one of our local CCIOs there. And as the important point is, we can only deal with this information and learn from it if we've caught it in the first instance. And right now, as we look across our operating theatres across the country, they are closed rooms in all senses of the word in terms of what we're surfacing in terms of data coming from that room and learning to surface the unwarranted variation that happens between theatres. These are highly protocolised areas, and it's still unbelievable to me the lack of standardisation across theatres, even in the same theatre suite. So being able to surface what that variation is and learn from it, where is having the better outcomes, is really key. Next slide, thanks, Aimee. So what have we done? We have built Flight Deck, which essentially is our flight deck recorder for operating theatres. It's an intelligent AI-driven ambient voice capture piece of technology that sits within the operating theatre and provides a real-time dashboard back into the room, as well as monitoring stations outside, that provide the transcription of the conversations that are having segmented speech and sentiment analysis. Really important. So live in the room in real time, there are nudges to suggest that the sentiment is positive, negative or neutral, and behaviours are slipping potentially. There's lots of keyword classifications that have been put in as well to help with nudges where protocol that's been built into Flight Deck hasn't been heard. So for one of our pilot sites, they're very interested to look at their swab count process. They had errors across their swab count process. Flight Deck in their instance has been built to really analyse what's going on in that space, and I'll show you a dashboard shortly, just one moment. Of course, it then creates a library of transcripts for the organisation to go back and learn from, but in fact it's that real-time capture in the dashboard in the room that's proved most poignant and useful and impactful for the staff on the floor there. Next slide, thank you, Aimee. And again, thank you. Here it is, working in an operating theatre in one of our pilot sites. And the point is, you can't see it. It's frictionless. It's not in the way of everyone getting on and doing their role. It should be an enabler to enhance or improve performance, behaviours, and could deliver insights that are meaningful to the team in the moment. And that's exactly how it's been designed to be used. It's non-intrusive and doesn't add friction. In fact, what we're saying right now is how can we actually start surfacing this in context of the patient's record within the core electronic patient record. So really looking again at how we can iterate upon its standalone qualities and impacts that it's delivering back. Thanks, Aimee. This is the live dashboard at one of our pilot sites. So within the operating theatre, they'll be able to see this on a screen. And again, they can customise this to their own view. But the most important thing that's come up time and time again has been the ability to see that graphical representation of the sentiment in the room, and a sentiment is dropping off into a negative space, being able to look at what's going on and what's happening in the room there. Action items, questions, topics are all caught and segmented as well, and these have proved useful. Various different use cases want to focus on various different parts of the dashboard. And on the right hand side, the compliance aspect that I spoke about earlier, particularly for looking at the protocol around swab count in this particular example. Again, being able to nudge in the real time what has been missed or heard or not heard as it was. In one of our very early pilots on part of our beta testing, this had been live not an hour within the operating theatre before the staff within the theatre decided they were all standing in the wrong spaces, they had the kit in the wrong place, and actually could improve the way they communicated with each other by some minor amendments about where things were being done in the room. And it was lovely to watch that organically happen without getting in the way of the core business at the end of the day. Next slide, thank you. So last, just to finish on, this was built really with that operating theatre and that second victim syndrome in mind. How can we really affect and shift the dial in terms of moving to that system learning and be able to put data, as we learned from our HIMSS journey, in the hands of clinicians who are best able to interpret and change and make and better outcomes. What we've learned very recently, though, we've had a poll to pilot in the space around virtual care, telehealth and urgent health actually being delivered via some of the big 111 providers, is to use Flight Deck less in that in-person care scenario, but more in terms of plug into the phones, what can it do around that prompting, and again, that live in real time nudging to do the right thing, and again, can be taught the protocols that are around safety netting and various other things that want to be looked at. Again, all in the mind of what are those human factors that are impacting outcomes and how can we surface those and analyse those. Thanks, Aimee. I think that's us done. And really happy to take any questions. And there's no ask here from us. We're always out looking for development partners and people interested in using, drawing this down and looking at how it might be utilised for different use cases, hence the recent pivot into telehealth. But yeah, happy to take any questions. Thank you, and thanks for your patience with the faults at the beginning.
Thank you so much, Amanda. That was fascinating and really interesting to see the crux of the challenge that you're trying to address, which is that safety and that, do no harm, how to enable best care. Really interesting, the analogy, the comparison with the aircraft team, actually. So thank you very much. Are there questions from the room, thoughts or even feedback for Amanda? Stunned silence. Okay, in that case, Amanda, would it be okay to share your contact details in case people have questions and want to follow up later? And a comment from Chris in the chat. Really nice to see something other than a one-to-one consultation style ambient AI. That data one is brilliant. So much work on human factors this would help with. Yeah.
That's great. That's what we think. Thanks, Laura. Thanks for the opportunity to speak to it. Oh.
No, was that a hand up, Alistair? Was that it's gone down again? Okay, I assume not. Thank you very much. So in that case, that brings us to the end of the supplier demonstrations. We had thought about going back into breakouts to kind of have a discussion about what further questions or support people might need in terms of introducing ambient voice technology in Scribes. But I am aware it's been quite a long day, and we do recognise that people slip out as soon as we say the breakout words. So please do add your thoughts to the link that was put into the chat earlier. We're really keen to capture where people think this would be useful, but where the concerns are, so we can stand up appropriate support as and where we can. We've also, thanks to Aimee, put in a link in the chat for a feedback form. Again, please do feedback on this event and ideas for future sessions that you would find useful. I'm keen that this is a series to think about how we can effectively but safely deploy AI across a range of different settings and clinical areas. So really keen to hear from you as to what would be useful. We will stay here now, so if there is comments or things you'd like to flag, please do so. But otherwise, please fill in the feedback form. And thank you very much for joining us today.